Hello. Let me know when to start. Start. Hello. Good morning, friends and colleagues. It gives me a great pleasure to welcome you all to our hybrid webinar on pediatrics. Amidst the upcoming Omicron threat, and as many associations have joined us today in our webinar, I request all the association heads and the committee members to request the authorities to authorize a booster shot for all the healthcare workers as soon as possible. Amidst this threat, it is our second CME on simultaneous physical and virtual platforms. We are very thankful to Sir H.N. Reliance Hospital for providing us a platform to hold our monthly CMEs for last so many years. Today, we have a panel of reputed pediatricians, Dr. Taral Nagda, Dr. Kiran Sathe, Dr. Sweta Bansal, Dr. Pankaj Parekh, Dr. Raul Verma, and Dr. Bruchel Shamkova, addressing us and enlightening us on various pediatric dilemmas we encounter in our day-to-day practice. My special thanks to Dr. Anil Mehta, Dr. Jawahar Mukhtiar, and the scientific committee for excellent organization of monthly CMS. We are fortunate to be joined by the Bombay Medical Union, Sir H.N. Reliance Hospital, GPA, FFAPI, the Bombay A Ward and D Ward Medical Associations, as well as Jet Doctors Federation. I now hand over to Dr. Anil Mehta for further proceedings.
Thank you. And very good morning on this Sunday. We are sorry, normally we are on the first Sundays of every month. So this is being a second Sunday, but I wish you a very good morning. We have a very nice Feast of Pediatrics program today. Before that, I would like to make a couple of announcements. To be or not to be was always a problem that should we do physical, should we continue with the webinar? That was always a problem with me in this continuing pandemic. But then a little boldness, a little observing the COVID protocols, and we have decided, and with the help of Sir H.N. Reliance Hospital, we have decided that we must meet physically also, as well as we will try to relate on our webinar platform, that is the Bombay C Ward Medical Association YouTube channel. The second important thing I would like to announce that now we are talking all about Omicron. So our webinar come physical meet at H.N. Reliance Hospital will be on 2nd January. That is on the first Sunday of January month. And there we are going to have Dr. Zahir Udwadia, Dr. Tushar Shah, and other very renowned faculty, and we will be discussing the effect of Omicron virus in the continuing this pandemic. So please do tune to us on the 2nd of January at the same time by around 10:30. Secondly, I would announce here that we have today's program has been totally conceptualized by Dr. Raul Verma. He is the head of pediatric and he's the head of pediatric and neonatology at Sir H.N. Reliance Hospital. And he has made this entire today's program conceptualized and arranged it. So at the outset, I thank him, and we continue this program. Dr. Raul Verma completed his MBBS from University of Mumbai and then acquired a diploma in DCH from College of Physicians and Surgeons, Mumbai. Thereafter, he successfully pursued his MD Pediatrics from Mumbai University and further went to complete MRCP Pediatrics from Royal College of Physicians in UK. Dr. Verma is a leading pediatrician and neonatologist in Mumbai and has been consultant and head of the department at Bombay Hospital for several years earlier. And prior to this, he was a neonatology head in Wockhardt and Severely Hospital. Right now, he is the head of the department at H&R Reliance Foundation Hospital. At his credit, a lot of publications are there. And I thank Dr. Raul Verma to give us this opportunity to do this pediatric program. Now, our first speaker, I'd like to introduce, and then I will hand it over to Dr. Raul Verma. The first speaker is Dr. Taral Nagda. He is the pediatric orthopedic surgeon, and it's quite, my interaction with him for last 10, 15 years. And we have done a lot of cases together. The last one was correction of, some foot deformity, and where he had done some innovative ideas of taking the help of a 3D printer and making a proper model before doing a surgery. So that was something which I liked it, and then I said, okay, then can we have your lecture? So he's going to speak to us today on the this correction of deformities in pediatric practice. He's attached to SRCC Hospital, Jupiter Hospital, Hinduja Hospital, and Saifi Hospital. His special interests are pediatric hip, cerebral palsy, deformity corrections, and non-orthopedic, their interests are gadgets, farming, and reading. So may I call upon Dr. Taral Nagda, please come and take over the mic.
Same one which you opened. 3D. Okay. So good morning, everybody. Miracles happen in life, and it's miraculous that after now 8 months, I'm standing on my own feet for this talk. And I really want to thank everyone for their love, blessings, and prayers that this miracle has happened. I'll talk about this some other time, but today is a time to talk about a passion which I have. I always wanted to do engineering and then landed up into medicine. But that engineer in me always lived along, and that's why I took orthopedics. And then these are the combination of innovations which have happened because of being a doctor at soul, but engineer from the mind. So orthopedics, as all of you know, orthos means trait, and pedics is child. It's all about correcting deformities in children. And there are 3 dimensions to any image. And this is the 4th dimension which I'm going to talk about. So this is the child Dr. Anil Mehta was talking about when she came from Calcutta and had a foot deformity. You can notice that she has flat foot of very severe variety. Her feet are pointing outwards, and on the X-ray in the middle, you can see that there is a subluxation between talus and navicular bone. I'm going to point it out and show it to you. And on the lateral X-ray, you can see that the foot is absolutely flat. So this is what this girl had, and we had to correct it. And to correct it, what we did is we did a CT scan of the foot. We did a computerized modeling, and the entire surgery was planned in the lab of Indian Institute of Technology. Whole surgery was done virtually. And then we 3D printed a model of that foot and created a jig to do the surgery on a foot model. And then that surgery was recreated on the operation table. You can see what you see is a plastic jig through which various wires are going. And these wires correct deformity of the foot. The surgeon is just bystander. Our job become very easy. And just in 30 minutes, this complex foot deformity surgery was over because we spent a lot of time and took help of a computer to help us design it. So what is computer-assisted deformity correction in children? This is something which is very new. Even in developed countries like USA or Germany or UK, this concept is just arriving, and we are one of the first in India to do this thanks to our partnership with the engineer and technology team. And what we are going to sort of discuss in today's talk is what is computer-assisted deformity correction? How do we actually do it? And how is it going to help your patients recover in a more perfect manner and better? I'll just take example of this very common deformity in adolescent child. You can see that this child has knock knee, genu valgum, the knees are touching and ankles are far apart. And what these children have is difficulty in getting up, climbing stairs, and difficulty in running. And most of these symptoms are because of patellofemoral malalignment. And this needs to be corrected. The problem is this deformity should be corrected when the child is growing at age of 9 or 10 years. And what you can do, just modulate the growth with a screw and completely correct without any major surgery. But when child presents to you after the skeletal maturity, you have no option but to correct the deformity by doing an osteotomy. We have to become MCH, medical carpentry and hammering business. That is what we need to do at that time. And what we used to do, the planning of these used to be a paper plan. And the surgeon used to approximately correct the deformity on table, because on table, there are no guides, there are no angle measurements, and you go with the intuition of your eye to correct this deformity. So this is how the planning used to be done on X-rays all along. And this planning was always imperfect. Now, this is a 3D deformity, and 2D planning will not work. So computer-generated planning helps us because it is a 3D planning. It is precise to the degrees, because if it's precise, it's going to restore the alignment in the knee. And if it restores the alignment in the knee, that knee will last a lifetime and will not have to undergo knee replacement. All of us know that what is difference between a good furniture and bad furniture. A good carpenter is one which will align your doors perfectly well. And those doors will work even after 25 years. If the hinges of the doors are not aligned, those doors will become loose in 5 to 6 years. And same thing is true for a body. So it has to be precise. This computer-assisted planning is not just planning. It allows us to create jigs with 3D printing technology. And most importantly, how the child will look after surgery, you can see before the surgery and predict what the outcome. So these are some of the advantages of computer-generated planning. And all of us nowadays who renovate our houses have been using this. You ask your interior designer to do a computer-generated planning, and you can see how your house is going to look after the renovation. Before that, ladies in this audience use it to see their hairstyle. How I will look after the hairstyle is known before you do the hairstyle. So this is the same technology which is used. The process is to get a CT scan done first. Then we do segmentation of the data, which is done in the engineering lab. Then there is a virtual planning. Now, based on the virtual planning, we design a guide which is to be used intraoperatively. That guide is printed with a 3D printing technology because this is a patient-specific guide. And finally, we use that guide during the surgery and execute the surgery. So the data acquisition was doing a CT scan, and we had a lot of trouble here because CT scan is done in supine position, whereas the deformity is in standing position. So what we do is we take a standing scanogram, and the CT data is superimposed on the standing scamogram to give us a 3D standing image, which looks like this. And then engineers work on this. We work on virtual platforms. In pandemic has taught us a lot of things. We work with team viewers and various options of deformity correction they show, and we will select one. It is just like a lady going to a sari shop and saying, "Mera wala pink, I want that correction." and we can choose and tell this is the correction I want. And then they also allow us to customize the plate which we use during the surgery. If we make a printed plate, it will cost almost 2 lakh of rupees. Our patients can't afford that. So what we do is we ask them to make a jig to bend the plates, which will cost a lot less money. And this is how all it looks on table on the computerized screen. And I'm going to play a small video here to show how the things are done. Okay, so this is a small video and how the engineers would show us. This is a deformity, and this is the osteotomy, the guide in place, how the guide is going to work, cut out the wedge, correct the deformity, and after the correction, how a plate which has been bent is going to be fitted onto this correction. And when this is fitted, automatically the deformity would be corrected. So these are steps of the surgery which are going to happen. This is the guide which is 3D printed. This is completely autoclavable. So this comes to our operating room, and using this guide and the plate, we correct the patient. And you can see that on the left is the planning and on the right is execution. And all the patients which we have done using this technology, the error rate is 0.1%, which means we are able to correct what we plan and what we predict. And you can see that this patient's leg now is completely normal using this technology. So we need a doctor and engineer, a combination to do this. And the time we spend in the lab is actually much more than what we spend in the operation theater. Some of more complicated cases I'm going to share. This is a malunited forearm fracture. So forearm fracture which was treated in a plaster, malunited. And here the deformities are very complex. There is angulation, but there is also rotation. And there are 2 bones involved. So what we do again here, there is restriction of pronosupination. This child is not able to do the homework because most of the homework is done on the laptop. And if you cannot pronate your forearm, you cannot use the laptop. So this child was terribly, upset. He couldn't do that well. So what we did, we took X-rays, we did a CT scan, and after doing CT scan, this is how the deformity was planned for us. So you can see the whole process in this video. This is how CT scan of normal and abnormal side looks. We put the data of normal side on the abnormal side because we want to convert abnormal into the normal side. And that is the jig which was planned, the K-wires which are placed. And once these K-wires are aligned, you can see that entire rotation and correction in this is achieved. And this again is checked on the model first. We want to check that everything is okay. They also printed model of the deformed bone. We did surgery on the deformed bone in the lab, and final outcome we saw. And when we were satisfied, then actually the surgery was done on the patient, and then it was very easy. In the complex deformity, through small incision, you could correct all the deformities, put plates, and you can see that this child's range of movement, has absolutely normalized as it was before his injury. And these sort of results, even if you're the best surgeon, it's not possible if you do it just with your eyes and your hands. You require a third eye, and you require the third hand, which is the computer's eye and computer's hand, for you to be able to do this. Some more deformities, cubitus varus, very common deformity after a supracondylar fracture. And this child wanted to correct it. And here you cannot use plates. So what we did was we used an external fixator. Again, the same process, the process where we make a jig here. And using this jig, we corrected the deformity. Percutaneous surgery, no stitches, and it was completely corrected. We became a little more bolder, few more applications. So this is a child who has coxavara, a complex hip deformity. We need to correct it to make it completely normal. Again, same steps, doing a CT scan, going back to the engineers, they plan it on a 3D model, and again give you various options. Doctor, do you like this or this, which will work better scientifically? And what we select, they make a jig. This jig is 3D printed. We use this jig during the surgery. And advantage of using the jig is your surgery becomes absolutely like a meditation, because everything is pre-planned. It's like doing a prayer to the God. And when you do with that frame of mind, the outcomes become exactly perfect. So on the left, you can see how it was planned. On the right, it was executed. And here it is not surgeon's skill. It is the jig which is made by the computer, which has helped us to execute this surgery perfectly well. So in last 3 years or so, we have done number of these patients which has crossed 50. We have spoken about these procedures on numerous national platforms, but it was really nice when we were invited at Additive Manufacturing Meets Medicine. It's a prestigious conference in Germany held every year to talk about how we do this deformity correction. And recently there was a Formlabs Users Summit in USA, for which again, virtually, like how this meeting is happening, virtually we could participate in 2 sessions. And we were the only representatives from India who could show an exclusive work on this 3D printing technology and its use for correcting deformities. So take home message is, this is a technology which is available here. It's right here in Bombay. It's not expensive. It allows 3D correction, and we can use locally made plates and implants with our local people and minds doing this. And I'm sure this will go a long way in helping us to improve lives of children with deformities. So with this, I conclude my talk. If there are any questions or comments, I'm happy to take. Thank you very much.
This engineering part is done in a separate office, or is a part of your?
Right. So Dr. Pankaj Parekh is asking, is this engineering part done separately? So the answer is yes. We have a firm called Imaginarium. These were a bunch of young guys who were using 3D printing technology for making jewelry, customized jewelry or customized spectacles. And they had a good business, but they wanted some adventure in life, wanted to do something special. And there was a chance meet where we all met and started this work almost 4 years back together. So working together, what has become is they now know a lot of medicine, to the point that you just give them the X-ray and CT scan and they are able to plan the surgery perfectly well. At the same time, I've also learned to know a little bit of engineering and the programming, so that when one of them is absent or when they have trouble, we are also able to guide them. So there is a lot of engineering part involved in the whole process. It takes from the time you give them CT scan, nowadays within 3 days they are able to deliver the jig. So if we send them patient data on Saturday, on Wednesday I am able to use the jig on the operation table. So it's that quick now. Initially it used to take 2 to 3 weeks, but now the time has been reduced. Yes, sir. Yeah, it is PMMA. It's a additive plastic. It's a plastic material. We are also looking at material which is recyclable, meaning which you can dump in the ground after surgery and will dissolve and not add any problem to the environment. But currently, whatever material are used, most of the 3D printing materials are plastics. Yes, so 3D printing has various applications in medicine. The application, if for a oncosurgeon, they can get a model, they can make plates, they can make prosthesis through 3D printing. For a surgeon, they can have a liver, for a liver tumor, they can have a liver model and they will know exactly how much resection has to be done. If there is a breast cancer, there can be a model of the breast, and the implant for the after mastectomy can be pre-designed. So a lot of applications are possible. For people who are innovators, a lot of instruments can be now 3D printed, because previously all the instruments were made by big companies and you could not manufacture them if you had an idea or you required a small instrument for one patient. But with 3D printing technology, Dr. Parekh, if you need a special stethoscope for a particular condition, or if you want a customized stethoscope with your name written on it, it can be possible. I have used this 3D printing technology during my 25th wedding anniversary, where we took DNA of my wife and me, and we printed the DNA. So we made a pendant for my wife and a cufflink for me. My cufflink had her DNA and her necklace had my DNA. So any number of things can be done. The baby's first cry, you can have a soundgram, and that can be 3D printed as a memory for, I think, this hospital. We have neonatologists here, and Dr. Verma, you know, this can be gifted to every child which is born from this hospital. Yeah. Yeah, I'm not able to hear, doctor. Please, yeah. Come, you can come. Splints, no? Yes, excellent. So one more application which I did not speak about, we can make customized splints using 3D printed technology. So if there is a scoliosis patient, nowadays this scan the child's back. So they know what is the deformity like and make a customized 3D printed splint which exactly fits onto the body. I had a forearm fracture once, and they made a 3D printed fracture for a distal radial fracture for me, which was in position. So I agree that, you know, you imagine and anything can be designed with 3D printing.
Is this technology easily available to everybody?
Yes, it is easily available and very cheap now. Very, very cheap. So now a 3D printing machine, if a hospital has to install it, is going to cost just 15 lakh rupees, which is, you know, cost of an ultrasound machine.
Robot can be used for some benefits, and now the cost has gone down to 3 crore for many products.
Yeah. So these are different technologies. 3D printing and this computer-assisted deformity correction is for planning. And I think robot Dr. Joshi will talk to you about, but is about execution. So I'm sure there will be a combination of computerized planning and robotic execution. And when that happens, I think all of us will be just going to surgeon's room and drinking coffee. And that would be life of a surgeon. Yes. Thank you, sir. Thank you very much.
So it was an excellent presentation. And friends, you know, what Dr. Taral, I liked your one slide when there was a bullock cart. In the bullock cart, you had put in one horse. So when you are talking about even robotic intervention, there'll be 2 horses then. So that is a good one, and which I really like it. So right from the computer navigation, which we had witnessed during the knee replacement surgery, and see, look, the entire medicine is changing. So it's a wonderful experience. And friends, I think we are having a really feast of knowledge today. Now, I will request Dr. Raul Verma to come on the dais and take the program forward. Thank you.
Good morning, everyone. Nice to see so many people physically after a long time. I think COVID has really challenged us as far as our social norms and expectations are concerned. So without much ado about this, I welcome all of you to HM, and I'm very thankful for allowing us, Anil Bhai, to put up an interaction with problems with technology, but that's fine. So technology is good, Taral. I was really impressed. And first of all, happy to see you back on your feet. But technology has to be driven by human hands. So I think as long as we understand technology, it's a good slave for us. The moment we do not understand technology, we become its slave. So with that, so we'll have a series of lectures in the pediatric specialties. The first one would be put in by Dr. Kiran Sate. He'll be speaking about the importance of screening the pediatric population for urinary tract infection and its importance, because we believe that when we miss out urinary tract infections, there are a lot of long-term implications. That is one. The next lecture would be by Dr. Shweta Bansal. She is a pediatric hemato-oncologist, a bone marrow transplant specialist. She is extremely experienced and has started the BMT unit here almost 6 years back or 7 years back, and she continues to progress on the same. So she would be speaking on what happens when we have an abnormal CBC report. How concerned should we be, and what should be the next steps? The third lecture would be by Sir, Dr. Pankaj Parekh, sir, and he would speak about, we talk about a lot of vaccines, but then talking about general vaccines in 20 minutes is not a feasible thing. So sir will be focusing on the impact and the importance of the flu vaccine in current COVID times. Sir's, I don't think there's anyone in this hall who does not know or has not interacted with sir. He's our mentor in pediatrics and my guide for the same. And we welcome you, sir, for that. The next lecture would be by Prashant, I believe, who, as Taral indicated, would speak on laparoscopic and robotic surgery and its impact and the beauty of the science behind robotic surgery. So Prashant, welcome and thank you very much for joining us. I would talk a bit on COVID vaccination and the current status of the same with respect to children. And finally, I would like to introduce Dr. Bruchel Shamkova, who's our consultant pediatric intensivist. She would speak on dengue, which I think now we find quite a lot actually. Surprisingly, from whatever I've heard from my data, it seems to exceed malaria, and which is very, very concerning because, of course, it's logical because the Aedes mosquito actually bites you in the daytime too, while the malarial mosquito was restricted to only evening times. So now instead of just shutting our doors and windows between 5:30 and 7:30, we need to shut our doors and windows 24/7. Which is not such a great thing to happen, but Bruchel will touch upon management of dengue. So this is going to be the basket of pediatrics, and I welcome everyone. Once again, thank you very much, Anil Bhai. And we'll take it step by step. Questions can come in at the end, and the next speaker would come in. Yeah, thank you very much.
So, good morning, everyone, respected seniors and dear colleagues. And I would like to thank the IMA and HR Hospital for giving us this opportunity to present at this forum on pediatric illnesses. So, as we know, infections is a very common occurrence in growing children, and except for the very few minor serious infections, most of these infections are going to be self-limiting viral infections, which get better within a couple of days. And except for just supportive management is what is required, and only in a few percentage of cases, short course of antibiotics to get rid of the illnesses may be required. While these infections do not have much complications in the future period, there are certain infections which should be definitely not missed, and if we miss them in the acute phase, they are bound to have long-term complications and serious illnesses to be encountered later on. And one of these infections are the urinary tract infections. And it is a common topic which is discussed in almost every forum pertaining to children. And the reason being that even when we know that it is such a serious infection which needs to be picked up on time and managed promptly accordingly, there are certain scenarios where we are not sure whether this is actually a urinary tract infection or it is just some pus cells which are found in a child who has fever. So there are always certain controversies and certain confusion which needs to be cleared whenever we're dealing with these infections.
Sorry for that. I think slides are not moving ahead. Do you want to stop it? Do it again. Is it moving? Okay. Right. So there is always a situation where we underdiagnose UTI. Sometimes we overdiagnose and sometimes we misdiagnose. So we would like to see what exactly do we need to consider when we encounter a child who has got a fever and a suspected UTI. So as we know, unlike other organs which are bound to get infections like respiratory, which is so commonly involved in any infections, urinary tract of a child is a very well protected system. And as we can see here, that it's a unidirectional flow of urine starting from the kidneys and down through the ureters into the bladder. And there are protective mechanisms which prevent the backflow of the urine in the reverse direction, because of which usually the tract is free of infections. And whenever we have a urinary tract infection developing in any child, usually there will be some underlying cause why a child gets a urinary tract infection, especially in boys who are found to have UTI very early in life, and even in those children who present with recurrent UTI. So apart from the diagnosis of UTI and making a diagnosis of UTI in a given child, there is certain else other component that also we need to undertake, that is the further evaluation of a child who has got a UTI. So how commonly do we find UTI? It's fairly common. 3% of girls and 1% of boys have symptomatic UTI below 11 years of age. And the maximum risk is in the early years of life, the first year especially being the most important. Now, there are certain risk factors as we discussed. Any child who gets UTI will have certain reasons why he's getting UTI. It could be a part of the bloodstream infection like a sepsis, which ultimately causes urinary tract infection. It could be an ascending infection right from the bladder, and if there is a vesiculated reflux, the bacteria might gain entry into the urinary tract and the kidneys, and it can lead to pyelonephritis. It could be as a result of certain procedures like a catheterization if it is done, and that could be getting complicated. It could be a congenital obstructive uropathy like a PUJ obstruction or a PU valves, or any kind of obstructive uropathy which is seen in these children. Any abnormal connection between the gut and the renal system, like a fistula, like a recto-urethral fistula, where the gut organisms can get entry into the urinary tract. Renal stones, which are so commonly seen in children nowadays because of the faulty diet and lack of less water intake. Constipation, again, becoming very important in children. Bladder bowel dysfunction, rather neglected area in busy office practice, but this could be a very important risk factor for acquiring new infections. And bad perineal hygiene, prolonged use of diapers, and improper washing after the toilet. So bladder bowel dysfunction is a very important topic that is now being discussed in each and every forum pertaining to UTI. How do we suspect a child has a bladder bowel dysfunction? So when you take a cursory history in a busy practice, you can just ask how often does a child go to the toilet. So if the mother says that he usually tends to go to the toilet and he's busy sitting with his mobile and is busy enjoying his video games, so that could be the situation if the child has got recurrent UTI. So postponing the need to go to the toilet. Running whenever he wants to go to the toilet, he will usually run and go, and in the meantime he might just wet his undergarments. So that is one important history that you could take. When often they assume certain postures where they try to postpone the urge of going to the toilet by compressing these lower pelvic muscles. There could be history of going less frequently or more frequently, urgency, frequency, dysuria, and bedwetting. So these are certain symptoms that you could ask the parents whose children have got urinary tract infection. So what are the dangers of acquiring UTI? Any child who has got UTI, and if it is not picked up in time and not managed adequately, there is a high chance that these may result into sequelae and renal scarring. So as we can appreciate, if there is an infection which starts in the bladder, and if there is a VUR, the bacteria gain entry into the kidney, and after the infection has resolved, it may usually leave behind sequelae in the form of renal scars. As we can appreciate here on a DMSA scan, this part of the kidney eventually becomes non-functional, and it's not just that it is non-functional, it will cause more problems by causing hypertension in the long term and risk of renal failure. So if there is a multiple scars in a given kidney, this could very well lead into a renal insufficiency as the child grows and as the metabolic demands on the body increase. So this is some, these are the basic kinds of reflux related scars which could be seen on the postmortem samples in our anatomy discussion, as we could see. So these are the areas of scars and the loss of kidney volume, which could be seen in these children later on. So the sequelae are basically scarring, hypertension, recurrent UTI, acute kidney injury. So they can at times come with acute rising creatinine because of the renal insufficiency, if it is a bilateral pyelonephritis or a systemic spread of infection and a chronic kidney disease. So we need to be very clear and accurate in picking up any child who has got a UTI, and what are the symptoms that we should look out for. Many of these children could have non-specific symptoms that makes the things more complicated. They could just come with some non-localizing symptoms like fever for a few days. They could come with poor feeding, vomiting, lethargy. They could have even jaundice has been reported as one of the symptoms in the newborn period of UTI. And in older children, when they are able to localize that this is localizing to the urinary tract, they could complain of pain in the abdomen or dysuria while passing urine, or they could have chills with fever and pain in the lumbar region or the loin area, as we could appreciate it. And so these could be the symptoms in the older children that we should look out for. Whenever we suspect that this child has symptoms which could be related to UTI, we have to promptly do certain tests, and the basic test that we would do is the urine routine, because urine routine would tell us how much are the pus cells, and for making a diagnosis you would have at least more than 5 to 10 pus cells in a freshly collected sample of urine. And if it is associated with symptoms, so you need to have all these criteria to make a diagnosis of probable UTI. There have to be symptoms suggestive of UTI. It is not just that you just in any child with fever you send a urine routine and you call it as a UTI. There have to be certain symptoms, pyuria, bacteria. So there have to be bacteria in addition to the pyuria, and significant growth of single species of organisms. So if you are suspecting a UTI, you would also do a urine culture. You would not start antibiotics before collecting a urine culture. That is the first mistake that often is done. So collect the sample of urine culture before giving the first dose of antibiotic, and it should be in a properly collected manner, a midstream collected sample. So ask the child to void and tell the parents to just clean the genital area with soap and water and discard the initial part of the urine, collect the middle part and send it for culture. And this should be sent promptly, and within almost 30 minutes, it should be sent to the microbiology lab and should be plated. So if you waste a lot of time in collecting the urine and sending it to the lab, there is a risk of contamination and it can give rise to false reports. So when you have all these criteria met, and if you get a significant growth of single species of organism on urine culture, which is more than typically 1 lakh colonies on a urine culture in a midstream sample, you would be fairly certain that this is in fact a case of UTI. Now there are certain other easy methods of suspecting and screening UTI. So we have these dipsticks which are easily available, and they can assist us in making a diagnosis of a probable UTI. So what exactly do we do with these tests is we look for 2 tests, the urinary nitrate and leukocyte esterase. So these are 2 tests which, if there is a likelihood of a UTI, would come positive. Nitrates basically in presence of bacteria would get converted from nitrate to nitrite, and leukocyte esterase would become positive if there is a significant amount of leukocyturia because of the inflammation. So if you have both these tests positive, the probability of this being a UTI is much more. So in a busy OPD, when you do not have much time to be with the patient, you can at least do a dipstick. Make sure that both the tests are positive. If they both are negative, then the probability goes down. If it is positive, then you would tell the parents that this could be a UTI, send a urine routine, send a urine culture, and then start empirical antibiotics, and then ask the patient to come for a follow-up with the urine culture report. And in the meantime, if the child gets better and if the culture comes negative, then this could very well be a certain other infection and not a UTI. So significant growth of organisms, as we know, different ways of doing it could be the midstream urine, which is most practical, could be done in the OPD practice. If the child is admitted, one could do in a non-toilet trained child, especially in a young child, one could do a simple urethral catheterization. It should not be a Foley's, a simple sterile catheterization, and you take it off, and as soon as you have got the culture, the sample, you just take off the catheter. In very exceptional situations, one would need to do a suprapubic aspiration, which is usually not a very favored thing, but that could be done if need arises. And that would be very, very specific in picking up infection. So as we could see, the probability of making a diagnosis goes higher up as you are using any of these invasive procedures. But for most practical purposes, a simple midstream urine would be sufficient. Important thing to note here is that often we overdiagnose UTI and we treat situations which should not be ideally treated. One of this is asymptomatic bacteriuria. So the similar situation where a child comes with fever, and when you do a urine routine, there may be some pus cells in the urine. And if it is not related to UTI, this could be very well a case of asymptomatic bacteriuria, or even when a child does not have fever and just for some non-specific abdominal pain, when you do urine routine, you might find some pus cells. So if you are finding basically some bacteria. So if you find some bacteria without pus cells and without symptoms, this could very well be a case of asymptomatic bacteriuria. And ideally, studies say that these situations should not be treated because basically these bacteria are the commensals or the healthy commensals, and which usually help in preventing a major UTI. But if you treat without any definite indication such cases, then you are likely to replace these healthy commensals with a harmful bacteria, and in the future these children may land with frank UTI. These are usually seen in older children and does not lead to long-term problems. So one should be very careful in making a diagnosis of UTI and avoid overdiagnosis. Do all children need hospitalization? So there are certain clear-cut indications which children should be hospitalized for treatment of UTI. So especially neonates and children below 3 months of age, the recent guidelines say that these children are at a very high risk of developing pyelonephritis and they would need hospitalization and IV antibiotics at least in the initial 48 to 72 hours. Otherwise, all the other older children could be very well started with oral antibiotics, and a close follow-up would be important to make sure that they are getting better with the antibiotic that has been started. So high persistent fever even after 48 hours, sick looking child, vomiting, dehydration, where oral intake is going to be not that good. If there is a situation where we have a palpable bladder or obstructive uropathy, like a PU valve, even there you need to hospitalize these children for a more definitive management, like a IV antibiotics and then a surgical procedure. Or if there is any other like high creatinine, if the child already has a renal insufficiency, and a non-E. coli UTI. As we know, E. coli are most common organisms contributing to 70% of the UTI cases. And if it is a resistant organism, then it would not be safe to just put them on some oral antibiotics, and better clearance of this infection by IV antibiotics would be important. Because if you do not treat within the first 40 to 72 hours, the risk of scarring goes much higher. And then there is a likelihood that there could be sequelae. So when you treat a child with UTI, ensure good hydration, ensure that the parents keep giving frequent feeds to the child. Empirical antibiotics could be in the form of third generation cephalosporins or aminoglycosides as indicated, and it should be given in appropriate dose and appropriate duration. So there is no shortcut, and if you are making a diagnosis of UTI, it is important to complete the course of at least 10 days of antibiotics. Right? It could be initial 48 to 72 hours of IV antibiotics and followed by oral antibiotics, and the samples have to be collected properly, which goes without saying. What we need to see in the child who has been started on antibiotics is that clinical response has to be documented, that if the child was having fever, high fever, vomiting, lethargy, dehydration, all these symptoms have to improve, and a return of the normal well-being has to be documented. So that could be the strong indicator that whatever infection you are treating is getting better with the antibiotics that has been started. If you do not find a good clinical response within 48 to 72 hours, that is an indication that you need to reconsider your diagnosis or reconsider the antibiotics that you have started based on the cultural sensitivity report that you will be getting within 48 hours. And if required, then you may have to change the antibiotics based on the sensitivity. It may often happen that you have started certain antibiotic and the child responds beautifully to the antibiotic, but the culture when you get is showing resistance to a particular antibiotic. So would you change the antibiotic just based on the report that you get? So basically that is the thing. If you have got a symptomatic improvement, and if the child has responded to the antibiotics that you have started, there is no need to just change the antibiotic based on the sensitivity report, because there is something called as a in vitro and in vivo sensitivity, which could be different. So you can happily continue with the same antibiotic and complete the course of 7 to 10 days. And at the end of the 7 to 10 days, what you may need is just document a urine routine that the pyuria and bacteria have got disappeared from the sample. And there is no need to repeat a urine culture. So that is another mistake that is often done, that we keep repeating cultures, and often it is found that the culture will invariably grow some organism or the other, and then rather we are treating the reports rather than the child. So that should not be done. Do not repeat a urine culture, just document a symptomatic improvement, clinical response, and a urine routine that is sufficient. But in a child who has got like significant resistant infection or presenting with a serious pyelonephritis, certain other evaluation is also mandatory. So even a single UTI in a boy has to be evaluated, because high risk of having underlying obstruction in the form of PU valve or any obstructive uropathy. Recurrent UTI in girls needs evaluation. There could be bladder bowel dysfunction or any other cause of UTI like a VUR, and certain other investigations like a ultrasound kidney, just to make sure that there is no obstruction, the kidneys are looking good sized, healthy, and there is nothing significant in the bladder. A DMSA scan later on could be required, especially in a young child who comes with a UTI, to note whether the child has got any sequel in the form of a scarring, because these are the children whom you would need a long-term monitoring for proteinuria, hypertension, and renal failure. And MCU in selected situations to define a VUR. So that's a MCU, as you can appreciate. In a child who had a UTI, it could very well be a posterior urethral valve with a dilated posterior urethra, or it could be a reflux, which could be seen in these children. And these children would then need a close follow-up with a specialist to make sure that they are not landing into complicated problems. So the Indian Society of Pediatric Nephrology has laid down certain guidelines that what you need to do in different age groups. If it is a very small child, less than 1 year, you would do sequentially most of these investigations, ultrasound, MCU, DMSA. And if it is an older child, only if indicated, you would do any of these tests. But ultrasound would be a good way to screen for any major problems. So just ending with two cases, an 8-month-old child who comes with a failure to thrive has a high-grade fever, and the urine routine showed 40 to 50 pus cells and bacteria. It was a leukocyte esterase positive and a nitrite positive on a dipstick, which was done. E. coli was showing more than 1 lakh colonies on urine culture. Child was given antibiotics, had UTI in the past. So now, as we see, this is an 8-month-old child, so less than 1 year, male child, and coming with a failure to thrive. So this is not a simple UTI, which would just start antibiotics, complete the course, and then send the child away. This child needs to be under follow-up, because as we can appreciate, this child ultimately had a PU valve. And if you do not address this problem, the child will come with repeated infections and even renal failure later. And so this child underwent a cystoscopy, a valve was identified, fulgurated, and later on he was put on initially prophylaxis, and thereafter he has been doing well. He's doing well with an improved weight gain. A 8-year-old girl, another common office practice scenario, comes with recurrent UTI with fever, some urinary infection on culture, normal ultrasound KUB, normal renal function. And when you take a detailed history, she happens to go to the washroom very often. The mother says that, every hour or half an hour she rushes to the toilet, and also complains of abdominal pain and tends to, postpone going to the washroom, and often has bedwetting and stools with blood, constipation. So this is a scenario where it is a bladder bowel dysfunction, and unless you address this situation, the child will not get completely rid of the urinary tract infections, and eventually this might lead to renal scarring. So the key messages is that the prompt evaluation of UTI, making sure that this is in fact a UTI and nothing else, has to be first priority. And infants and young children are at a high risk for developing renal scarring and kidney affection. So they have to be treated promptly, hospitalization wherever required, and a focused evaluation to identify underlying cause causing the kidney infection. A single confirmed UTI also has to be taken seriously, and it should not be just considered like a simple URTI. So it's a completely different story. Patients with recurrent UTI and a VUR should be evaluated for bladder bowel dysfunction. So take a history in your office practice, at least a cursory screening, and that would give you a wealth of information as to which children need further evaluation. Thank you. Are there any questions? Yeah, so that could be the other situation where if you are not able to having access to lab immediately, you could keep it in the refrigerator at a lower shelf and then take it as soon as possible, because that is not the best way to send a sample. But if there is a limitation and if you do not have access to the lab immediately, then that could be certain compromise situation, but that could be done. Pardon?
8 out of 10 patients are of UTI. Empirically, the patient of PO below 1 year, 8 out of 10 patients are of UTI. That is correct.
It's not that common. I think that is a very high percentage, but yeah, at least 40 to 50% in a PO, as you would rightly said, could be having probable UTI. Because 8 out of 10 is almost 80% to have UTI. It's not that common also. As we could see, the percentage is 3% below 11 years of age. So it is a less common but important infection, which should not be missed. Okay, is that complete? Yeah.
Thank you very much, Dr. Sathe. And the most important carry-on message, which I would also give it to the our general practitioners. Whenever we have fever in children, what we should do is that first and foremost, every time we should always think of UTI first, and at least one sample of urine is sent. Then we'll be catching a lot of UTIs, which is missed on a lot of time, and we tend to start antibiotics, then they are not fully treated. So this is the most important message, and when we should always suspect whenever there is a fever, first urine infection has to be ruled out. Now we have Shweta Bansal. Dr. Shweta Bansal is a pediatric hematologist, and she is going to discuss about the abnormal CBC report and how to catch the sinister diseases. May I have Dr. Shweta? Thank you.
Thank you, everyone. Thank you, sir. Good morning, everybody. And I really thank Dr. Mehta, sir, and Dr. Raul Verma, and all organizers of this meeting, giving me the opportunity to speak on this important topic, which is abnormal blood counts in a child in a community. As we all know that many children, they have some abnormality in the blood counts when they come to our OPD practice. So it's very, very important to tell us, or we need to understand, like, patients need a proper investigation and which patients can be just can be treated on an OPD basis. So today I'm going to talk about the various case discussions as per the lineage affected, whether it is a hemoglobin, WBC, or platelets, and approach to reach a diagnosis and the relevant investigations for the possible diagnosis and the treatment and ultimate management. So we'll have some few take-home messages and learning points about this thing. So whenever we are looking at the CBC report, we definitely look at the blood counts and we look at the abnormality, whether it is in the single line or whether multiple lines are affected. Then we look whether the patient is having anemia or polycythemia. Polycythemia, we don't see that common in children. Mostly it is because of the dehydration. So anemia is the much more common abnormality related to the hemoglobin line. Then we can have a leukopenia or leukocytosis, or thrombocytopenia and thrombocytosis, and other additional findings can also be seen in the CBC, which we'll come to know later as we go through the cases. So peripheral smear examination is always an important part. And actually, this gives us a clue whether there is any bone marrow abnormality is there or not. So if we need to do a bone marrow examination, before that, a proper peripheral smear examination should always be done. And whenever we are looking at the anemia, we should always look at the MCV, MCH, and CHC to see the size of the RBCs and also to see whether the hemoglobin is normal or on the lower side or on the higher side. Actually, that also gives us the clue towards the diagnosis. Similarly, the differential counts, we need to see whether the neutrophils, eosinophils, leukocytes, whichever is present. And whenever we're looking at the thrombocytopenia and thrombocytosis, it is very, very important to look at the mean platelet volume and definitely then treatment approach. So I first goes towards the hemoglobin disorders. So these are the 5 cases which are kept over here. I have purposely kept all these 5 cases together just so that you can at a glance see what are the differences which are present, even if the patient is presenting with a single kind of abnormality, that is a hemoglobin low. So I mostly get severe anemia to see in my OPD because mostly the moderate and mild anemias, they can be treated on OPD basis and they have a dietary problems. So now looking at the first 2 cases, that is case 1 and case 2, these children, they are less than 1 year old. Both are male babies and they have a hemoglobin within the range of 4.5 and 6.5. They don't have any other abnormality. WBC and platelet count are normal. So now looking at the other parameters, so we'll go to the case discussion now. So the first case had low hemoglobin, but he had no interest. So whenever a small child who's presenting with a low hemoglobin, always try to rule out whether there is any hemolysis or not. Mostly they can have a ABO compatibility, starting from ABO compatibility to pyruvate kinase deficiency to G6PD deficiency. Many other problems can be present. So if there is no interest, then you have to worry more actually. So the patient had no hepatosplenomegaly, his HbSC, HbF was 30%, creatinine count was on the low side, no abnormal cells were seen in the smear. So if anybody see these reports, maybe they say that, okay, maybe not big problem is there, but I would say that there is a big problem if we are not able to see any abnormal cells in the smear and creatinine count is also on the lower side. So differential diagnoses for these patients were pueril cell aplasia and other, as I said, pyruvate kinase deficiency, hereditary spherocytosis, and G6PD deficiency, and maybe parvovirus infection. So we did the bone marrow in this patient, and the patient had deficient erythroid progenitor cells, and we made a diagnosis of diamond anemia. So in these cases, we mostly start the patient with blood transfusion, and as the patient grows, maybe 7 or 8 months, we start the steroids also. And sometimes they respond, sometimes they don't respond. And ultimate cure for these patients is bone marrow transplant. Now coming to the second case, how it is different from the first case. The second case one is presenting at the age of 7 months. Hemoglobin is 6.5. It is having a low MCV but normal RBC count. So the patient had hepatosplenomegaly. HbSC showed HbF of 90%, retic count 3%, target cells were seen. Anybody can guess what would be the diagnosis? So this, yeah. So the patient had a family history of consanguineous marriage and hemoglobinopathy, thal major is there, and both the parents' HPLC should be done in these cases to have a complete diagnosis, and both had a thal trait that they were minor. Now coming to the third case, this patient had an age of 1 year, female, had a WBC count of 6.4 with platelet count slightly on the higher side. So when you see anemia with the WBC count, with the platelet count on the higher side, the first diagnosis should be iron deficiency anemia, but let's see what happens in this case. So in this case, we did the peripheral smear examination. The patient had teardrop cells, hypochromia, and endocytosis. So iron studies were sent for this patient, had a low serum iron, high TBIC, and low serum ferritin. So iron deficiency diagnosis was definitely, as we suspected on the first clinical picture only, it was made. But iron deficiency anemia is always a symptom. It is never a diagnosis. So we have to find out the cause why the patient is having iron deficiency, especially at the age of 1 year. So this patient, when the mother was probed, the patient mother told that the patient is having a blood in the stools. And when we sent the stools for the examination, there was a frank blood. And we did the colonoscopy of this patient, and he was diagnosed with, she was diagnosed with Crohn's disease. So a differential diagnosis is very, very important. These children, they can be missed, they can have Crohn's disease, they can have celiac disease, they can have a dietary deficiency and worm infestations. So definitely finding out the cause for iron deficiency is always important. And in this case, we did not give oral iron because the gut absorption was poor because of the basic pathology. So we gave intravenous iron to this patient. Now coming to the last 2 cases of anemia, in this, the patients were older age, 10 years and 14 years, 1 male and 1 female. They presented with anemia, but other lineages are also affected. So they have a low platelet count as well as a WBC count are borderline. So, but the other thing we can see is that one is having an MCV of 70, which is a borderline lower side, and other is having an MCV 102, which is on the higher side. So on these 2 bases, we can see which can be more problematic and which cannot be that problematic, but difficult to say again. So let's see about the cases. So case 4, hemoglobin 5.8 with pancytopenia, hemoglobin low with borderline platelet count. Significant history in this patient is always ask how they are feeling. So the patient was saying that I'm not feeling well. There is an easy fatigue, not able to concentrate in the studies, decreased occasional fever is there and decreased appetite is there. But there was no loss of weight at this point of time. On examination, patient had a liver spleen, liver of 2 centimeters, spleen was just palpable, and peripheral smear did not show any abnormal cells. Now what to do? So there was a significant history and there is a pancytopenia. Now, so we convinced the parents that we are suspecting something more serious. So we did the bone marrow of this patient and we found the patient to have an acute leukemia. Now coming to the next case, 14-year-old child, hemoglobin. Again, the patient had a low hemoglobin, severe pancytopenia, but here the history was different. In this, the patient was having a diarrhea on and off for last 2 months. She was going to school and she was eating in a canteen and she was having a diarrhea. So diarrhea was attributed to that. And she, at home, she is like a Jan. So she was having a completely vegetarian diet. There was no liver and no spleen palpable. And so if you're not having a liver and spleen with severe pancytopenia, again, you have to think like what exactly is happening to the patient. So peripheral smear again had no abnormal cells. So our first differential diagnosis may be because of the dietary issues and all those issues. Maybe the patient is having a dietary problems, megaloblastic anemia, or otherwise could be having a aplastic anemia. So before going for the bone marrow, which can help us in diagnosing the aplastic or leukemia, we reviewed the peripheral smear again ourselves. And we found few hypersegmented cells, and we sent the B12 level of the patient. The B12 of the patient was low, 87 only, and hence bone marrow was not done, and the patient was given B12 supplements, and her counts came completely normal. So this is how we can approach. So peripheral smear examination, the complete examination of the history definitely helps us in reaching the diagnosis of the patient. So so for thalassemia, we give again the blood transfusions, and even the diamond blackfan anemia, we give blood transfusions. And ultimately, for both of them, the cure is bone marrow transplant. And other cases for the leukemia, we have to do the risk stratification, and accordingly, we can treat the patient. Now, coming to the second abnormality, which is related to the WBC counts, whether there is a leukopenia and leukocytosis. So again, I have taken 5 cases together. So in this, again, at different time points, different ages they are presenting. So looking at the first 2 cases, they are presenting at very young age. One is actually presenting at the age of day 3 only. So this patient actually, when he presented with the 3-day and a WBC count of 1.5 lakh, when I was called, I saw the patient. He had a slanting eyes and short neck and seam increase. So you can say with this feature, the patient is actually a Down syndrome patient. So peripheral smear showed 70% large. He was having a hepatosplenomegaly, hypotonia, and dyspnea also. And there was a systolic murmur, which was VSD. So the patient diagnosis was definitely made. It was easy to make. The patient was having a transient myeloproliferative disorder. And this transient myeloproliferative disorder can be seen in 10% of Down syndrome cases. And 20 to 30% they develop ultimately a AML M7, which requires a lot of intensive treatment in first 4 years of life. So any patient of TMD with their Down syndrome needs a follow-up of at least 4 to 5 years. So if they don't develop any leukemia within this time span, they don't have any problem later on. So treatment for this patient was low-dose cytarabine because the patient was symptomatic and has a hepatosplenomegaly also. And he responded very well and was doing well after that. Now, coming to the second case, this patient was 2-year-old, 50,000 WBC count. So I was called because the WBC count was on the high side. Patient was having pneumonia and also had a high CRP. So differential diagnoses were definitely leukemia, whether it is a leukemia, whether it is a leukomoid reaction, or whether it is a CML, which can be commonly present, have this kind of a presentation. So we did the peripheral smear examination. There were increased neutrophils and there were toxic granules were seen. So once you see toxic granules, you can be sure like maybe this is just a leukomoid reaction, but definitely you have to follow up the cases. So initially we made a leukomoid reaction kind of a diagnosis, and we gave patient IV antibiotics and upgraded further to higher generation antibiotics because the counts were not going down, and ultimately the counts became normal and the patient can be discharged without doing any other further investigation. Now coming to the third case, this was very interesting case. He was a 6-year-old girl who came walking in my OPD with WBC count of 2.4 lakhs and platelet count of 6 lakhs. So we were perplexed like what this patient is going to have. So the patient had no symptoms. She came walking in the OPD. Only history she was giving was that slight discomfort after having food. And when we examined the patient had a spleen of almost 6 centimeters below costal margin. And we did the peripheral smear. It showed predominantly a lot of basophils, a lot of myeloid series were seen. So we were seeing less RBCs, more of a WBCs actually. So preliminary diagnosis was chronic myeloid leukemia. Chronic myeloid leukemia can present in this age group. It is very, very uncommon in children, but can present in this age group. And we did the bone marrow examination and FISH studies, which were important to make a complete diagnosis. And the patient had a BCR ABL positive, which was translocation 922. And most importantly is that this is the first malignancy which had a targeted treatment. And we were able to give this patient oral tablet on an OPD basis. She has to come only 3 months, once in 3 months for the routine examination. And she was doing well. And she's in a complete hematological as well as molecular remission. Now coming to the leukopenia cases, we have discussed about the leukocytosis, how leukocytosis can affect in the differential diagnosis. Now coming to the leukopenia, how WBC count, low count can have a different diagnosis. So first case, we'll discuss pancytopenia. Patient had a hepatosplenomegaly, petechial spots were there on the body, and they were abnormal atypical cells. So this is a very, very typical picture of any leukemic patient. So any leukemic patients may not present with a WBC count on the higher side. They can present with the lower side also, and they can have a severe pancytopenia as well. So any severe pancytopenia with hepatosplenomegaly, always we should think about the first leukemia as a first diagnosis. So we did the bone marrow, and since we were suspecting the patient to be leukemia, we sent the samples for cytogenetics and NGS study also. Now these studies are very, very important. Now just making a diagnosis of acute lymphoblastic leukemia is not enough, because we can do a precision medicine or personalized treatment for this patient. And actually this patient had an abnormality which was translocation 119. And the significance is that if you are having a translocation 119 abnormality, this patient have a high risk of CNS relapse. So we have to give a lot of CNS directed treatment to these patients. And similarly with the NGS study, when we did, the patient again had Mmr deletion, which again tells us that the patient is going to have a very high risk of bone marrow relapse. And mostly these patients, even after doing the treatment, have a very high chance of relapse, and they have to go for a transplant. So just doing the treatment and diagnosis these now ALL patients is not enough. We have to further investigate them to actually a proper risk stratification, so that we can give a proper treatment to decrease the relapse. Now coming to the last case of leukopenia. So this patient had isolated neutropenia. He had a decreased neutrophil count. On physical examination showed warts on the back of the hand, and mostly near the knuckles. So history was that the child was admitted multiple times in a hospital for infection. So whenever a child who is presenting with an isolated neutropenia, having a warts on the hands and having a multiple admissions because of the infections, always we have to think about the immunodeficiency in these cases. So we did the immunoglobulin levels, and the patient had a hypogammaglobulinemia, and ultimately diagnosed to have a WIM syndrome, which is like WIM, W stands for warts, H stands for hypogammaglobulinemia, I stands for infections, and M stands for myelokathesis, which is a apoptosis of the myeloid cells in the bone marrow. And the treatment for these patients is the GCSF to be given, and we can give immunoglobulins. A bone marrow transplant we don't do in these patients. Mostly these are transient, and sometimes they improve also. So this is how we manage all these patients. For the Down syndrome, we gave cytarabine. For leukopenia, we gave antibiotics. Chronic myeloid leukemia, we treated with imatinib. And for ALL, we treat the ALL treatment. And for WIM syndrome, we gave the GCSF and IVIG. Now coming to the last abnormality, which is a platelet count abnormality, that is thrombocytopenia and thrombocytosis. So whenever we see a thrombocytopenia in our OPD basis, we always think about ITP. So ITP is definitely very, very common, but not that common also. So we have to think about some other diagnosis also in some of the patients with different features. So in this, again, the different age groups can tell us about, so age of a child is always very, very important, because you can have a congenital problems when the patients are presenting in a very early age, and you can have an infection problems or immunodeficiency problems when the patients are presenting in the later age. So this case 1 and case 2, first we'll talk. So this patient was a 3-month-old. He had a platelet count of 45,000 and MPV, that is a mean platelet volume, that the size of the platelet was very, very low. That was 6.5 also only. So there was no history of consanguinity, no family history of any bleeding disorder. Patient had skin rash and also bloody diarrhea. So whenever there is a combination of skin rash, bloody diarrhea with low mean platelet volume and a low platelet count, always think of a diagnosis which is a risk called Aldrich syndrome. It is an immunodeficiency syndrome. And we did the genetic testing of the patient, which came out to be positive. And ultimately, patient was started on low-dose steroids and IVIG and was offered PMT. But so far not has been done because the patient is still very small. But they have a very high risk of malignancy. Hence, a complete follow-up or regular follow-up is also required in this patient. Now, coming to the second case, again, this patient presented at the age of 7 months, platelet 85,000 with bleeding positive, and MPV was normal. So this patient had no pallor, no icterus, no active bleeding. He had there was a consanguineous marriage history, and on examination, patient had radial abnormalities with presence of both the thumbs. So X-ray hand was done. He had a bilateral absent radius, and the diagnosis of thrombocytopenia with absent radii was made. And treatment is to manage the bleeding problems because, again, this is kind of a transient thrombocytopenia. They sometimes improve also. And bone marrow transplant is not indicated. But making a diagnosis is very important because you can counsel the parent what exactly the patient is going through. So now coming to the third case, it is a very common kind of a problem. So 4-year-old male child, WBC count, HP is like slightly on the lower side, hemoglobin is, WBC count is 7,500, platelet is 60,000, and MPV is 12. So anybody can guess like what should be the diagnosis or what can be the diagnosis. So when I saw this report, I also made the diagnosis of ITP. But very interestingly, this patient had something different because this patient was admitted actually because of diarrhea. And the most important thing is that my registrar told me very interesting history that, madam, when we removed the cannula of this patient kept on bleeding for some time. Now the patient, anybody who is having a platelet count of 60,000 should not bleed that much. And especially with the platelet count of 60,000, again, should not have a petechial spots. So this patient had something different, not just a routine ITP kind of a thing. So we did the peripheral examination of this patient, and which was actually very important, and we saw a lot of large platelets. Again, the large platelets can be seen in ITP also, but there can be other problems also. So, another history important was a consanguinity history. The patient had, the parents were first-degree relations, and we did the platelet aggregation test and flow because we were thinking about some platelet functional abnormality, and the defect was seen in the GP1B95 complex, which is actually a complex in which the platelets helps getting bind into the von Willebrand factor, which helps in making the platelets as a break. So von Willebrand factor is like a cement, and if they are not able to get attached to the cement, they're not able to get attached to each other, and that's where the clot doesn't get formed. And ultimately, the diagnosis was Bernard-Sollier syndrome. So now this patient has in between some bleeding and all that, we try to manage tranexamic acid, and if there is a serious bleeding, we give platelets. So coming to the last two cases, which is this patient again presenting with the thrombocytosis. Now 10-year-old and 15-year-old girl. So this patient had a thrombocytosis. So any child, female child with a thrombocytosis with mild anemia with hepatosplenomegaly, you should always think about the connective tissue disorder. So actually this patient had high CRP also, mouth ulcers were there and joint pains. So this patient actually had some connective tissue disorder, maybe juvenile SLE, and was referred to rheumatologist for further management. So other patient, this patient had a low hemoglobin and WBC count was normal, but platelet was 6.5 lakh. So this patient recently has started menarche. She had a poor intake. She was on dieting and all that. She was irritable, again, not able to concentrate. We did the serum iron studies and a simple diagnosis of iron deficiency was made. So thrombocytosis with anemia, definitely iron deficiency is always the first diagnosis. So this is how we manage the patient. The key messages are good clinical examination and history taking is always very important. And sequential investigations should be done to reach diagnosis, not to jump to the bone marrow aspiration, because sometimes the bone marrow aspiration is not going to help you in reaching the diagnosis. Peripheral smear gives you a lot of information, even the X-ray wherever it is required. So all these investigations are important in a sequence. Bone marrow aspiration again can be avoided in many cases if careful examination of the smear is done, and judicious use of ancillary tests should be done. So learning point is correct diagnosis and proper management of the patient, and BMT is cure for many congenital conditions as well. So this is the email ID where if you can send any queries there, and I'll be happy to answer. And if there are any questions right now, I'm happy to answer them as well. Thank you.
One question here.
Yes, sir.
in a busy OPD practice, when you have a CBC report in front of you, there is a deficient, there is a hemoglobin is low, MCV, MCH both are low. So to differentiate between ideal versus the thalassemia trait, how do we do that from a only simple? Many times some lab write, they will write that, you look for a HB electrophoresis, or other labs may not write in some reports.
So actually, I forgot to show it in my, I'll just show that. I think I just missed to tell that point. It is a very, very important point. So
idea versus
yes. So if you see in this patient, so there is a thalassemia. This is 6.5 hemoglobin. This was a patient with this thing, and RBC count was high, 4.5. And whenever there is an IDA deficiency, the patient RBC count will be on the lower side. So from that only we almost calculate our Mmr index also. So if your Mmr index, if your RBC count is on the lower side, your Mmr index will be on the lower side, and your diagnosis will be going towards the iron deficiency anemia. And similarly, on the other side, you will be making a diagnosis of thalassemia. So RBC count is very, very important. So thalassemia major, they will have a RBC count on the higher side, mostly 4 millions. More than 4 million sometimes, or maybe like more than 3.5 million. And iron deficiency, RBC count will always be on the lower side. And second point is RDW. When we see RDW in the thalassemia major, we don't see too much variation in the RDW. They are mostly within the range of 15, 16 like this. But in the iron deficiency, especially in the severe iron deficiency, they can be in the range of 18 to 20 to 21, something like that. So these two features, if we see.
High RDW is in favor of.
High RDW and low RBC count. So these two factors can easily tell you this is more of an iron deficiency anemia rather than that. Thanks.
Thank you, Dr. Bansal. It was a very informative session. In a very simple way, and the comparison chart between the 5 cases given on one slide was wonderful. Well appreciated. So now we are coming to Dr. Pankaj Parekh. Dr. Pankaj Parekh is going to speak about the importance of flu vaccine in this scenario of pandemic. So let us hear from the master, Dr. Pankaj Parekh.
Change the slide, this. Good afternoon. At the outset, I must thank Anil, Dr. Anil Mehta, President Dr. Kamlesh Shah, and our Director of Pediatric Sciences, Dr. Raul Verma. Ever since the corona has come in the picture, last 2 years, our thinking has changed. Most of us have got a lot of information from known medical sources, and WhatsApp is top on the list. The various things have been talked about corona. Before the vaccines were given, we all were taking hydroxychloroquine. Vitamin C, zinc has been used in such a large quantity that I'm very sure if there was something like hypervitaminosis C, most of us would have got hypervitaminosis C. The corona vaccine has been given phenomenally well in our country. But in pediatrics, we are still waiting, maybe for various political reasons and for probably the number of doses we require, so the availability of the vaccines for the pediatric. I'm sure Dr. Raul Verma will talk in detail. Because once this vaccine comes, pediatric vaccine will be 3 doses and not 2 doses. How it will be given, everything is still secret. But I can assure you one thing, that pediatric vaccine will be extremely useful, and particularly when we start schooling and colleges. I think this vaccine will be given to children about 2 years of age. Now, before this vaccine comes, if you see the corona, most of the deaths have occurred in the early part of the corona epidemics, not because of the virulence of the organism, but it's probably ill understanding on the part of a medical fraternity. We initially never knew how to manage corona patients. 1.5 years back, everything was given, but without proper realization, what are we doing? It was something like throwing stone in the dark, and we lost many patients. To lose today patients, his only reason is he comes very late to the institute. But anybody who comes early is not very difficult to save the life. Now, why are we worried about flu? All of us have seen that corona affects primarily lungs. How does influenza infection related to a corona? If you remember, few months back, there was an interview on a television from the government representatives and representatives of Indian Academy of Pediatrics. And they talked about flu vaccine partly protecting corona. And believe me, this was a bomb. In 24 hours after that, in my clinic, we gave 30 influenza vaccines, explaining, no explaining, sir, you give it if there is no major side effect. Really, does this vaccine help us? There was a thought about that India is such a thickly populated country as compared to USA and Europe. And we have huge way of celebrating various festivals like Diwali, Eid, and surprisingly, we didn't have third wave. The third wave was anticipated because after these celebrations, the way in which people gather together in markets, we have seen on TV, we have seen in newspapers. Still, why the infection did not spread? We have given a good number of vaccines, but still we have to give second dose to many, many people. So what is protecting us? Why we are better? Various postulations, various theories were thought about. Some people thought that we have got so many infections with the viral diseases in the past that we are partially immune to these viruses. People even talked about BCG, people even talked about flu vaccines. People thought that BCG vaccines gives a protection because BCG always increases your T cell immunity. The reaction of BCG is due to T cell response, and that immunity might be protecting, but nobody has any proof. It was just talked about. Nobody, no scientific person has approved this. So in that case, are we justified in giving vaccines, which is preventable of any lung complication? Now, if you look at the flu virus, it's a small virus. This is a basic understanding. Something nice to understand. Flu virus is a RNA virus, single strain RNA virus, orthomixo virus group. This virus is a small virus. Now, if you take simple thinking, there's a small virus and there's a large virus. Hepatitis A, for example, is a large virus. When hepatitis A comes to the body, it remains in the body for a longer time, but it does not affect multi-system. All of us have seen this. Even if you don't do this, the virulence is never that bad to jeopardize the person's health. But if you see small viruses, like flu virus to a certain extent, COVID virus is a small virus, Zika is a small virus, Ebola is a small virus. These viruses, when they enter the body, their multiplicity is much faster, number one. Affecting multi-system is very common as compared to large viruses, number two. And number three, which is very important, is frequent mutations, which we have seen in this virus. Now, we have been witnessing mutations in influenza viruses for years together. That's why WHO gives formula every year, new year. We'll talk about that in detail. But this is just to give you little basic understanding that these small viruses, particularly RNA viruses, Ebola, Zika, Corona, influenza, and I'm very sure many more such will come because we have done enough damage to the nature. So these viruses are virulent, and when they change, with the major antigenic changes, it can create havoc. The Spanish virus, Spanish flu in 1957 killed millions of people. Do we have answer? No, we don't have answer. Can anybody say about Corona when it will go away? Nobody can tell that. Are we sure that we will not have such viruses in future which can really hamper human beings' survival, challenge the existence of the human beings on the earth? You never know. Is it going to be a floods? Is going to be a drought? Or is going to be a virus which is going to end the existence of the human being on the earth? Nobody knows. But viruses are dangerous. So among all these viruses, normally I love to talk about vaccines. When I talk about vaccines, I love to talk about 2, 3, 4 vaccines. If time permits today, I will talk about pneumonia in short, but flu virus vaccine is very important now. Important because it's a respiratory virus. Influenza affects upper respiratory system and lower respiratory system. But it affects upper respiratory system 4 times more commonly than the lower respiratory system. We'll talk about, there was a small study done in a low-income group countries like Cambodia, China, India, Mongolia, Mali. Some 1,000 children with double-blind trial was done. And all the children under 5 years of age, which were admitted in the hospital, and as a proved pneumonia on X-ray, their nasopharyngeal swab was taken for 19 viruses and 5 bacteria RT-PCR. 42.2% of these children showed streptococci pneumonia as a cause in bacteria, but 8.4% showed influenza as a cause of pneumonia. Respiratory syncytial virus, we call it as RSV, flu virus are few of the viruses which can cause significant pneumonia, particularly if the person or a child is immunocompromised. Okay, so the flu vaccine is important. So with this in background, how these small viruses can be troublesome, and if particularly if the patient is, if the baby has got corona, 3-year-old child was found to have Omicron. If everybody has read in the paper, the youngest child. This child can be secondarily infected with these viruses because once the corona affects the lung, there is a decrease, you are immunocompromised as far as the lung is concerned. And that tissue can accept any other nosocomial virus also or bacteria as a pathogen very quickly. So these vaccines are very, very important. Flu vaccine, paramount important. Little bit if time permits, 2 minutes on pneumonia vaccine. So let's see the flu vaccine. Is a single-stranded RNA. And there are 3 types of viruses: influenza A, influenza B, influenza C. Influenza virus affects human beings, birds, and animals. Influenza A virus can affect everyone. Influenza A viruses are usually moderate to severe illnesses. This can make you sick and it can last for a little longer time. Influenza B is a milder disease, affects only human beings and more commonly children, and more commonly upper respiratory tract infection. All those cases of URTI, throat infection, cough, cold, is by influenza is influenza B, majority of the time. Influenza C is of not any significance. It does not cause any disease in any mammals, and it never causes epidemics. Now, if you see any influenza virus, if you see the bottom of the slide, A California 7009 H1N, this is how influenza virus is described. Now, this is whenever you see this, even in a literature given with the vaccine, you will see this. Now, what does very easy for you to remember? How do you remember? A and H1N1, the first and the last two are type and subtype. So this is a bit influenza A virus, subtype H1N1. So it's type and subtype. If you see California in 2009 is the country of origin and year of origin. So it shows the origin of the virus, country and the year. So we have types, subtypes, and the origin of virus, country, and the year. And the 7 is a strain type. Now, what is a strain type important? Because all the flu vaccines are strain specific. A flu vaccine made for 7 strain cannot benefit strain number 10 and cannot benefit strain number 5. So this is a strain specific vaccine. So if you see of all these 5 things down, the middle one is most important as far as the vaccine is concerned. Right? Very easy to remember this. So whenever you see this vaccine, next time you'll be much wiser to pick up this when this has come. Because every year the formula might change. Now, like how other viruses, even influenza viruses change. I'll give you an example. When Corona came, Alpha, Beta, then came Delta. These are all Greek nomenclature. And then Omicron came, right? Now, these are all viruses which are because of frequent mutations. We have been hearing about mutation. Now, there are 2 ways the mutations can occur. A minor mutation like alpha to beta, delta, Omicron now they say is very mild. So these are mild antigenic variants, mild antigenic changes, and these are seen usually in influenza A and B, and they are called the antigenic drift. Drift is a small change, not significant. It may not increase the pathogenicity. Even the vaccine may not have to change with the drift. That's why it's now proved, even USA has said, that mRNA vaccine produced by Pfizer is good for Omicron. Similarly, the Indian scientists have said both our vaccines are good for Omicron. So this does not change the vaccine composition. So drift is good. Okay, every virus drifts. Today we get headlines in the paper, but why Corona? Our flu viruses have been mutating for years together. Then there is an antigenic shift, which is very important. A simple flu virus can become a swine flu and can kill 2 lakhs of people like that. 2009 May, swine flu came to India and we have so many deaths. It is still flu virus, but with antigenic shift. So shift is a major change. It causes major change in pathogenicity. So this is important. So what I was talking about, H1N1 was 2000, main swine flu was a major shift. And that's why this vaccine has to be changed periodically. Every time you have to change the vaccine. Sorry, did I change? Oh, I get to another one. Now, WHO, that's why gives a vaccine schedule. When do we take, did I miss any slide? Just sorry. Okay. So the composition of the vaccine has to be changed every year. It may not change, but If suppose you have to take vaccine, I would suggest that every doctor here should take flu vaccine, or every person above 50 years, even with normal immunity, should take flu vaccine every year, and more so all of us, because we are exposed to a lot of patients. Like I always insisted before also, if you attended my lecture, please all of you must take one Prevena dose. It's a one dose in a lifelong which can prevent you and protect you from streptococcal pneumonia. Similarly, it's advisable to take flu vaccine every year. Now, when to take this vaccine? The new formula WHO has got GISRS. This is influenza surveillance and response system, which gives a formula, and it gives formula to Southern Hemisphere in September and to Northern Hemisphere in February. So any change, it depends on the epidemiology, the existing viruses, the formula changes. As I was telling you, of those 5 things, types, subtypes may remain same, but the country of origin might change, the year of origin might change, and main important thing is strain type will change and make you a particularly strain specific vaccine. So if you see the epidemics in the past of a flu, in 1918, 1917, we had H1N1, which was called as a Spanish flu. None of us were there probably. In 1957, H2N2 came. These are all major changes, major mutation changes, antigenic shift. This was known as Asian flu. In 1968, H3N3 came, which is Hong Kong flu. And now in 2009 May, again H1N1 like a Spanish flu, but with a different mutation. And we called it as a swine flu. So these are a few of the epidemics which this has caused. That's why it's very important to take vaccine. Please take vaccine. Now, India is geographically in Northern Hemisphere. So what we get vaccine is in February. The formula comes, it takes around 4 to 6 months for a vaccine manufacturing company to make that vaccine. So the formula which comes in February, the latest vaccine should be ready in August. So we get in August somewhere the monsoon, right? Influenza viruses can have major role to play in monsoon and in winter. In northern India, we have more influenza infection in winter. In southern India, we have more influenza infection. But if you take in August or July, it will protect you for 1 year. And this formula holds true for the full country. Okay. So this is how it would, all these viruses, when they lose their virulence, we hope that coronavirus also loses the influence. From epidemic problem, it becomes endemic problem. Swine flu, which was epidemic in 2000, now is endemic. So when they lose their virulence, and then you have many drifts don't trouble, many drifted variants existing at the same time, but it does not make any difference. So this is how a pandemic flu killed, I told you, around 2 lakhs people in 2000. Illness rate is higher among the children, 20 to 40%. In adults, it is 5 to 10%. Hospitalization rates are much higher in children below 1 year of age. And particularly all those children who have got an existing lower respiratory tract, like a case of severe asthma, chronic asthma, cystic fibrosis. All those cases where compromised lung will have a problem. 2 types of vaccines, inactivated vaccine and live attenuated vaccine. What we use is inactivated vaccine. I tell you in a nutshell the manufacturing. There will be 3 options available to make a live attenuated, inactivated vaccine. The whole virus, that we should take whole virus. Very simple, but it causes a lot of side effects. No use now. Split product is a part of virus. This is when they use highly purified influenza virus, right? And they make a split product out of it, which contains hyaluronic acid and neuraminidase. And these are split products. We have 9 companies manufacturing flu vaccines. Sanofi Pasteur, GSK, Abbott, Zydus Cadila, Lupin, so many. And now all these companies are coming with a quadrivalent vaccine and not trivalent vaccine. I'll tell you in a nutshell about that. So in subunit surface antigen, only one company made. If you heard the name Agripala, a Panacea Antibiotics made this vaccine, and this was the only subunit surface antigen formulation. Major all other vaccines are split product. Wholesale, as I said, a lot of reaction not used. Most of them are split products. It contains purified hemagglutinin and neuraminidase. There is a vaccines are trivalent or monovalent, and now we can say quadrivalent. Quadrivalent means one more B is, we have 2 types of A, 1 type of B in trivalent. In quadrivalent, 2 type A and 2 type B. B is otherwise also not very, I would say it's more of a marketing gimmick, because they are giving in the same price, and somebody says, instead of doctor, you are injecting 3, why not inject 4? And then we don't lose anything. We'll talk about monovalent vaccine. These are novel vaccine made by Serum Institute of India, not used in India. It's only for the export to the countries where this particular strain was troubling them. So one thing is certain, the Indian companies like Serum Institute and Biotics are doing wonderful, phenomenal job in many vaccine manufacturing. These are a formula for 2010-11 vaccines. If you see type A, there are 2 strains, and type B. The 4th type which is used is B. Phuket 3073-2013, which is not written here, is a 4th B strain we use. The doses we use for these vaccines are 3 doses of 0.25 ml. The earliest you can give is 6 months. You can't give earlier than 6 months. Simple thing. 6 months to 3 years, 0.25 ml, 3 years onwards, 0.5 ml. Right? And up to 8 years of age, you require 2 doses at 1 month interval. At 9 years onwards, 1 dose is good enough to prevent the disease. The vaccine provides around 70 to 90% efficacy against laboratory confirmed diseases, 25 to 40% reduction in hospitalization, particularly in elderly, and 40 to 75% reduction in mortality in influenza season. So a good vaccine. The flu vaccine effectiveness depends at what age you are giving, and whether this vaccine is covering the existing flu virus in the thing. The side effects are mild, very mild, link between, and the most important side which we worry about, which was too much spoken about, was Guillain-Barré syndrome, which is probably less than 1 case per million are vaccinated. Little bit about information about live attenuated vaccine. We are not using this vaccine. It's a nasal vaccine. A beautiful vaccine because the virus enters through the nose. So there's a primary shield at the entry only. Highly effective vaccine, but can be given only about 2 years of age. And most of the influenza infections are below 2 years of age. So that's why this vaccine never became popular. A superior efficacy, there's no doubt about it. And particularly children below 5 years of age. Side effect includes fever, mild. This is side effect of injectable vaccines, fever, rash, GBS we talked about. This is live attenuated vaccine, and this has been some side effect. You can't give this vaccine to a pregnant woman. You can't give this vaccine to children who have a lot of low respiratory chronic problem, like chronic asthma, you can't give this. And children who are sensitive to egg, because these are all in chick embryo. So egg protein allergy. Now egg protein allergy is simple, is a contraindication. There are many children who eat egg and get urticaria. It's not a contraindication to vaccine. It's only anaphylaxis to egg protein is absolute contraindication to give these vaccines. Okay, very mild systemic reaction. live novel H1N1 was the name 2009, which Serum Institute made only for the export purposes. Whom to give? Let everybody should take it, particularly after 2009 swine flu epidemic. Government of India has recommended flu vaccine to everyone. All the children is fine, but they are particularly important to the children at high risk, immunodeficiency patient, cardiac, pulmonary, renal diseases, long-term aspirin therapy. Somebody will ask why long-term aspirin therapy? The chances of Ray's syndrome increases with this. And any child with asthma, which requires a long-term steroid, influenza vaccine is very important. Okay, thank you very much. So nice. I think I will not talk about the time does not permit. Thank you so much.
What a fantastic explanation. I must thank you, sir. And to explain to people, your own understanding is to the highest, sir. Thank you very much for explaining in the most and simplest language. Now we have Dr. Prashant Joshi. He is going to speak about role of minimal access and robotic pediatric surgery. Thank you.
Respected Dr. Mehta, Dr. Shah, Dr. Raul Verma, Dr. Pankaj Parikh sir, senior colleagues, all the doctors from CPOT Association and various other associations who are present in the auditorium and who are watching this presentation online. Good afternoon, everybody. Thanks a lot for giving me this opportunity to present minimal access and robotic pediatric surgery. The purpose of this presentation is to enhance the already existing knowledge amongst all the doctors regarding the laparoscopic surgery, which we are doing in pediatrics since more than almost 2 decades now. And since the last decade, the use of robotics in pediatric surgery has also increased because of the awareness and all. So I would like to give an overview of that and the recent advances which are happening, which is technology driven after the superb lecture given in the morning by Dr. Taran Lagda and various other good lectures in between. So I start my presentation by the collage which was created to be by my students in the previous hospital. These are all my publications. So how will we go about the lecture? It will be introduction to laparoscopic and minimal access surgery, a brief history about it, the basic principles which we use, the instruments which are different from the adult instruments which we use, the indications of laparoscopy in pediatric surgery and pediatric urology, and the modernizations which includes the robotics and the 5G technology which we are using, and the telemedicine and telesurgery which is evolving, including the artificial intelligence. I will just touch upon it. So how did laparoscopy happen? So most important thing is that unless you think that you can do, you can never do. So first was the thought process of penetrating inside the abdomen without causing any scar, preferably to the umbilicus. So this led to the concept of laparoscopy way back around more than 100 years, which was also called minimal access surgery, keyhole surgery. And brief history is that initially the speculum was introduced in 460 to 375 BC. Then Leicester is responsible for the first thought process of laparoscopy. However, the first laparoscopy was performed in 1901 in adults. In 1920, benefits of CO2 gas and technology came so that we could insufflate the abdomen and then we can convert the diagnostic procedure into a therapeutic procedure. Then Very's needle came, Hopkins rod system and the visualization improved. Then 1960, automatic insufflation came. And recently we have laparoscopic procedures currently performed left, right, and center in the second half of the 20th century. So pediatric laparoscopy, regarding pediatric laparoscopy, it has been first described by Kelling in 1923. However, the first case was reported by Stephen Gaze in 1971. and in his landmark publication, Advances in Endoscopy and in Infants and Children. So what is the basic principle? Basic principle is to examine the abdomen after creating insufflation in the abdominal cavity, peritoneal cavity, either by gas. So which is the cheapest gas available is CO2. Now what happens is it requires insertion of the cannula into the abdomen. So there are two methods by which we introduce. One is the closed entry and second is the open entry. The closed entry is the Berry's needle. We generally, it's basically done in adults and obese children and in the adolescent period. However, in small children less than 10 years and in infants, we use the open Hassan's technique. These are the two types of trocars which we use. This is the Berry's needle, and that is the open Hassan's trocar. That is the first trocar for insufflation. Which is the gas used for insufflation? It is the CO2, because actually in children as compared to the adults, there is no space. So you have to insufflate the abdomen at a particular pressure. I will come to it with a particular flow rate depending on the weight of the child. CO2 gas is used because most important answer is it does not support combustion. So there will not be any fire or anything inside when you are using electromechanism system for achieving hemostasis. So CO2 that way it is cheap, it is available, and it does not support combustion, and hence it is the preferred modality of insufflating the abdomen. The air pressure with this is 12 to 80 millimeters of mercury in older children. As the child is less, we initially go with 10 ml of Hg with the flow rate of, depending upon the age of the child and the weight, 0.3 liters per minute, 0.5 and 1 liter per minute. We don't increase the air pressure because what happens is because it increases the venous return, and hence that is the reason that we don't increase the air pressure or the flow rate beyond a particular point. So this is classic mechanism of insufflating the abdomen, putting the first trocar. It is a very needle, and then you can see the pressure monitoring and the flow rate on the monitor. Now, there was initial thought process that which is the safe entry point for diagnostic. Definitely it is umbilicus, but for therapeutic purpose, umbilicus still remains a safe entry point because the main purpose is of osmosis. That is one. And second thing is that it does not cause more wound infection as compared to other points in the abdomen. If you divide the abdomen into 9 quadrants, of course, and postoperative ventral hernia is same as that of the other portion of the abdomen. So umbilicus is the preferred primary point, and also this in the center. And second thing is that now where you keep the monitor, where you are going to visualize. Okay. So monitor is just kept above the target organ. For example, if you are operating in the pelvis, the monitor will be above the pelvis. If you are operating on the left side, monitor will be above the left side. And the scope is exactly opposite to that. Working instruments should be parallel to each other so that the triangularization is achieved. I would like to emphasize on this because this concept is very important in robotics. Because once you talk to the robot, you cannot change the position. This concept is important for more for laparoscopy, not much for robotic, because otherwise it will not dock only. Leverage concept should be here exactly in the center. Means the trocar should be half in and half out. Otherwise, you will be operating at the shoulder and you will get fatigue. You will not be operating at the wrist. These are the ideal angles. It's basically of theoretical purpose. So the valve system, in order to prevent the gas from escaping outside, which we have insufflated, there are flap valves and slip valves available. The slip valves are available in disposable ports. The flap valves are in the reusable ports. The instruments which we use specifically in pediatric are of size 3 mm and 5 mm. Miniature laparoscopy instruments are 2 mm in size. Mostly these are Maryland dissectors, endobracket, Hunter bowel graspers, scissors, traumatic bowel graspers. This is the harmonic scalpel which we use for hemostasis, so that whenever there is bleeding, it works on the ultrasonic mechanism. Now, what was the thing which was preventing doctors from adopting the laparoscopic surgery as compared to open? See, anything you compare it with open surgery. Is the suturing. So what certain innovations which have happened is the endoloop. Endoloop is already there is a loop. You just have to put it and tighten it. You don't need to suture it. So these innovations, technological innovations, have made more and more doctors adopt laparoscopy and do it. Second is the clip applicator. In laparoscopic cholecystectomy, nobody takes a stitch. Everybody applies a clip only. So there is a clip applicator. Suction irrigation, so that to suck the blood, whichever, if in case bleeding happens inside. Now the laparoscopic pediatric surgery, as I told you, it started in the second half of the last half of the 20th century, and since it has been growing like anything. The initially what was the concern is the child is small, the bladder is intra-abdominal, the liver and kidney are big organs. Then what is the need. The healing is also faster in children. However, the reasons behind the increasing popularity is basically it is procedure driven, modeled by the success in the adults. Now in pediatric also people are doing it, and because of the awareness which has increased in the adults, the parents themselves are asking for minimal access surgery to be performed on the child. And second is technology driven. Initially the adult instruments were only available. There was no specific pediatric instrument available. Now the pediatric instruments have also become available, which are much smaller than the adult instruments. And third is physician driven. Whoever is driven for minimal access surgery will do. But as far as I am concerned, physician driven is very important, because when you speak with the parent, how do you decrease the anxiety of the parent? Because for example, in adults, most of the adults must have lived half of their life and then they'll end up in laparoscopic surgery, cholecystectomy and all. Still they go for cosmetic purpose, but the child, he has to live his entire life. So if the cosmetic, forget about cosmetic, if it is a very keyhole surgery, if he is adopting, then the entire life he will be scarless, right? So that is the way that you counsel the parents regarding it. Now the positive effects is that the pulmonary function tests are better maintained. There is less, as far as abdomen is concerned, there are less amount of adhesions, inflammatory response is less, so the stay in the hospital is less, discharge is early. Coming to the indications which are commonly done in pediatric for laparoscopy, first is diagnostic, definitely. So non-specific abdominal pain. I mean that topic was planned initially because since I had already taken in C-ward, D-ward, common pediatric cellular problems and abdominal pain. So non-specific abdominal pain, if it is not settling, then you do CT scan and all. Still there is persistent pain, and then sometimes you diagnostic laparoscopy, you find Meckel's diabetic. I will just show all the slides of laparoscopy which we have performed over the years, right from inception since 2014 over here. So other indications are adenoidectomy, appendicectomy. Imagine adenoidectomy, appendicectomy, you don't require suturing at all, and envelope and everything is available. So you just have to go inside with the basic training. Even at student level in Science and KM, at student level these procedures are done. It is that common now. And in pediatric urology, in localization and evaluation of impalpable undissected testis, for example, the testis, if it is not palpable, initially it used to be to take a big incision, go retroperitoneal because it might be below the kidney. Now with the laparoscopy, you can do it easily. You can not only diagnose, you can do therapeutic also. Second is orchidopexy, staged orchidopexy, spermatic vein ligation, varicocele. I will just show some pictures of that, which we have done in our hospital. Retroperitoneoscopy is restricted generally to children more than 5 years because as such, peritoneum also doesn't have any space. And retroperitoneum, you just have to put a glove and the space is less. So generally, I personally prefer of children between 5 years to 15 years and with adequate weight. So operative technique, as I already told you, the first put is to the umbilicus most of the times. Then there is insufflation with the flow rate specific to the age group of the child. Then once it is introduced, according to the triangulation, the area of interest, put the working trocars. Then the CO2 gas is insufflated. And then you start the surgery. While inserting the trocars, you prevent any vessel injury and any other complications which arise. By experience, you can do it. Commonest performed procedure is laparoscopic appendicectomy. You can see that you hold the appendix with one port. You can cauterize the mesoappendix. And once you have cauterized the envelope, which I have showed you, you can envelope, you can directly tighten it. There is no need to take suture. And once you cut the appendix after tightening the envelope, you can remove it. Laparoscopic cholecystectomy, again, no suturing required. Clip applicator, this is an interesting case. In children, the indications are less as compared to the adults, wherein the multiple stones are there. In children, the either so it is gallbladder polyp or biliary stones. So this is a classical case. It's already been published. It's a gallbladder polyp with a single stone, more than 1 centimeter stone, more than 1 centimeter gallbladder polyp. Laparoscopy color triangle. You can see cholecystectomy. Choledochal cyst is congenital thing. Laparoscopic excision of choledochal cyst. You can see clip applicator. The gallbladder has already been clipped. Then dissection of the choledochal cyst. You can see the space handy scar. You can see. Now, hydrated cyst, even during open surgeries, it used to be difficult. We wanted to prevent the spillage, to prevent anomaly shock. What happens? Such a nice suction irrigation, which I had showed you initially, is available. That you can, once you small cauterize, you can directly put a suction irrigation within the mother cyst. The entire mother cyst can come out like this without any spillage at all. Fundoplication, it's a very, very standard procedure nowadays. Laparoscopic fundoplication. The important thing which I would like to emphasize is you have to dissect in the first 5 centimeters of the esophagogastric cancer. This picture is at a diaphragm with open surgery, huge incision from the right from the middle till the subcostal incision. Mercedes-Benz incision used to be given. This can be done with very small ports. After mobilizing the skeletonizing the esophagus, you can do the fundic prep. This is the fundic prep going is the suturing. Laparoscopic anal malformation pull through, wherein the anus is not there. and the rectum opens in the bladder. You can clip the bladder. There is no need to take sutures also, and then you can mobilize and create a neovenous like this. Endoinal pull through for Hirschsprung's disease. Hirschsprung's disease also nowadays can be done laparoscopically. Otherwise, there used to be big hockey stick incision in the lower abdomen, which used to remain throughout the life. Again, the adhesion complex. So you can. There are two procedures. One is in the pelvis. One is in the abdomen by laparoscopy. You can just take a mucosal tunnel. You can remove the ganglionic segment. You can mobilize the colon and then bring it out the ganglionic colon outside, and then to create a neovenous. Now, diagnostic laparoscopy initially, remember I told you, continuously child non-specific penny. Meckel's can also negative. This is Meckel's diverticle, which we found on diagnostic laparoscopy, and then suturing was done. Laparoscopic hernia repair. Now, although hernia is a simple surgery open-wise, laparoscopic hernia repair comes in advanced laparoscopy because you have to take sutures in that. Okay, so first thing sutures generally we take. Personally, I prefer laparoscopic hernia surgery for females because in males it's a very small incision, hardly one stitch comes or maximum 2 stitches. In females, it can be bilateral, or if a male child is bilateral hernia, then we give the option of laparoscopy or laparoscopic hernia repair. Laparoscopic orchidopexy is reserved for testis which is inside the abdomen. If the testis is outside the abdomen, you do open orchidopexy. This is an interesting case done over here on laparoscopic adrenal cystectomy. You can see the kidney, a huge cyst above the. It's an adrenal sparing surgery where we remove the cyst without removing the adrenal. Peripocyte surgery, internal spermatic vein. You can see, you can loop it, and then, as I told you, clip applicator. You can clip it and then cut. No need to take suture. Ovarian cystectomy with ovarian surgery. Laparoscopic pyroplasty, suturing. Video-assisted thoracoscopic surgery for diaphragmatic hernia repair. This is commonly done. The youngest which we have operated is 1.7 kg over here. So complications includes visceral injury, injury to bladder, small bowel, which can be prevented by proper experience and being cautious while inserting the ports. Now coming to the robotic surgery and the advances. So it's a master, as Dr. Raul Verma sir said, that it should be the basic concept of robot. It's a master-slave robot. Everything is wired. It's not without wire. And there is a red button over here in the console so that the robot is under your control. If you feel that the robot is going rogue or it is not going, you can press the red button and everything will, the power only will go. Okay. And the monitoring system is with the Da Vinci system, which is monitoring all the robotic surgeries which are happening. This is the patient side. This is the basically control unit, just like a CPU of the computer who is monitoring everything. And this is the console where you can control the robot. So which has got 4 arms. One is the camera arm, and there are 3 working arms. In pediatric, generally we use 2 arms or means 3 arms. One is the camera and 2 arms. The 4th arm we rarely use, which is generally used in oncosurgery and adult urology procedures. So, as I told you, the triangularization initially is most important is robotic docking. What happens is once you dock the robot and after giving the position, then you cannot move, and the robotic arms will get docked. You will have to de-dock the robot and then dock again. So initial docking is very important. So this surgery is in the pelvis. So robot will come above it and the arms will get docked. Central port will be the camera port and other 2 ports will be the working ports. Mostly we use 3 ports only. The reason is the safety of child is very important. So 4th small port we use as a laparoscopy port. So the control is in our hands. Although the person who is operating sitting in the on the console is controlling the robot, one assistant whose job is very important should be present at the patient side with the laparoscopy port for suctioning and introducing the needle and all. Some few videos of specifically the surgeries which were routine means preferably offered to parents and done over here is robotic pyroplasty and robotic uterine re-implant. So you can see that the wrist movement and everything is very good in robot. I mean, there is 12 degrees of freedom just like the wrist as compared to the 2 or 3 degrees of freedom in laparoscopic surgery. Another problem is that in laparoscopic surgery you are dependent on the assistant for holding the camera. Here the camera is under your foot control. So I mean, adjusting is very easy and you don't need to tell anything because everything you are only controlling. So not only dissection and cutting is easy, suturing also becomes very easy. This is the robotic pyroplasty video. So this is the dilated pelvis which we are cutting, and Henderson-Hines pyroplasty. So yeah, so this will cut, and after cutting, we are suturing this, and this is the digestion. This is the digestion which we will put, so that. So like all wrist movements are there. That is the advantage. So there was a thing that time taken by for docking the robot and all is, half an hour, 1 hour more as compared to the laparoscopy. But problem is that in laparoscopy, since you are dependent on the assistant and there is fogging and all these problems are much more in laparoscopy, ultimate time takes the same because the time required for suturing is also less in the robotic procedure. Another thing is that the vision is very, very high. I mean, very nice three-dimensional vision in, unless it is 3D laparoscopy, three-dimensional laparoscopy where you have to wear the goggles and see. The robotic vision is 3-dimensional as compared to 2-dimensional vision of the laparoscopy. So suturing procedures preferably are better with respect to robotic. This is a uretary green implant, that's the bladder, that's the ureter, that's the ureter. This is the subdetrusor tunnel, and this is the suturing. You see the suturing, how nicely it is, just like open surgery. So coming about the recent advances, actually it has got, although they are recent, it has got delayed because of the COVID pandemic. Otherwise, the artificial intelligence meeting which was from the California, which we last had webinar only last year, it was almost the telemedicine was about to come in existence in US, but because of the pandemic and all, it has got delayed. So whatever currently, what are the advances in single incision laparoscopic surgery, which is already going on, mini laparoscopic surgery, 2 mm instrument which I had already mentioned, 3D laparoscopic surgery, robotic surgery, single incision, robotic surgery. I will just show the instruments of single incision robotic surgery, which is not over here. Pediatric robotic surgery instruments only we have and KDA has. The robotic instruments are 15 mm camera and 12 mm working ports for adults. For pediatric, it is 8 mm camera, 12 mm camera and 8 mm working ports, which we have and KDA has. No other hospital has. They are using adult ports in robotic for pediatric patients, in case if they are doing it. So this is a single port, this is a sales port. This is just like, I mean, putting a camera and putting umbilicus as the main use so that there is no other star at it. This is the gel port. These both ports are used in laparoscopy procedures. This is not for robotic. So that you can, many people directly put ports and working through the umbilicus without using it. However, the longevity of the instruments and the insulation gets goes. That's why these ports are used, so that the instrument doesn't get damaged. This is a follow-up photo of the robotic patient. Single incision robotic is the newer concept, wherein this is the camera port and the right arm controls the left side, left arm controls the right side. However, while you are operating, your right hand and the right side of the patient will be same. So what happens is, through the single incision, the robotic instrument goes and the electromechanical device is also mentioned like this. So that even if you want to use all the 4 arms of the robot, there will be only single incision. So in conclusion, both laparoscopy and robotic platforms have provided an impetus for innovations in surgery while preserving patient safety and post-operative outcomes. Now, as far as pediatric minimal access surgery is concerned, there is a great benefit from use of robot with the fine tissue manipulation required and the promise of improved cosmesis with minimal blood loss. This is the publication which we had done before starting the robotic surgery in order to create the awareness, following which we have come a long way now. Thank you.
Dr. Joshi, it was the best presentation. You can say that minimum 10 years work has been presented in 20 minutes. So I must congratulate, it's a quite condensely, you have made us aware of the entire process and this thing. We are more confident now to offer our patients laparoscopic or a robotic surgery. Now we have today's architect of the program, Dr. Raul Verma, and he is going to discuss about the latest problem. What we are facing is the COVID vaccination in children.
Thank you. So COVID has been, unfortunately, as I said, over the last 2 years, it has dampened everyone's spirit. Quite a few of our people, some of ourselves, have actually encountered COVID, got admitted. We lost a few, and we lost quite a few healthcare workers also. And I think this was a lesson taught to us that do not take things for granted and do be ready. So for the first time, we were portrayed as the armed forces instead of the armed forces itself. And I think that's an awakening for us. So went through the initial phases of COVID. We had the first wave quite early on, and then we had the rather disastrous second wave. Can't hear me? Sorry. Don't need to see my face, you need to see the slides. But anyway, okay, right, sorry about that. So getting a bit habituated now to try to remove the mask at times. It's, yeah, we can just, is that better? Yeah, so actually, I somehow can't seem to be, anyway, just leave that, it will just go off, I think, on its own. Yeah. So basically, going through the second wave also, which was quite disastrous, and I think it was expected, but then I think we reveled in the first wave, and it really caught us very badly. So you can see on the left-hand side, that shows the weekly average of prevalence of COVID across the age groups, right from April 2020 till date. So this is just 3 days old. This data keeps on getting updated. So as you can see, we had a very nice set of second wave. Sorry. And then on the right-hand side, we see the deaths. So mimics the second wave. We lost a lot more. Of course, this may not be completely replicative of the data from India, because for us, we are also learning how to now have data management. So how to manufacture, document, and then display the data so that it can help us for the future. And I think that is one of the few lessons COVID has really taught us. So on the right-hand side, as you can see, a similar wave mimicking. What is a bit alarming actually is if you see the end of the wave, there's a small increase going up there. Now, probably this is because of long COVID also coming in, but we need to be careful, because if we have deaths from COVID, but we are not showing a prevalence of COVID, there's a mismatch of data somewhere, and we need to be very careful about that. Coming to pediatrics, we've been a bit lucky. I mean, we are anticipating still some issues, but we've been very lucky, and the figure over here shows it very nicely. So what happens over here is, yeah. So what you can see is on the extreme left is the pediatric representation, and the total prevalence is 1%. So most of the COVID has occurred in the middle age. And then, of course, towards the end, once again, our elderly people have been spared. Some people say because they have been exposed to a lot of diseases in the past. Some people say because there are not enough of them to be documented. But anyway, I mean, I'm hoping it's the former. So overall, if you go to see pediatric COVID across the world, not just India, but across the world, seems to be doing much better off. Similarly, if you look at the death rates, once again, you'll find out that in the first 20 years, we talk about 18 years, the data is for 20 years, it's roughly 1%. So 0 to 10 years is about 0.5% mortality, and 11 to 20 is about 0.7. So 1.2% of the total mortality of COVID. So once again, I think we've been fortunate that we've been able to not get our children worried too much and getting it slightly better. So what is the virus? I mean, it's not just enough to know that we have vaccines possible for children. We also need to understand how does virus development take place so that we can decide maybe after a year or two, which would probably be the best set of vaccines available to us. So if you look at the virus, this is the coronavirus. So the important three particles which we look at is, one of them is the spike glycoprotein, also called as the spike antigen. Then we have the nucleocapsid, which is surrounding the RNA, so the N protein. Then we have other surface proteins, for example, the envelope antigen, which also now is being used in our RT-PCRs to detect COVID. We have the RNA, which is the main protein subunit for replication. And then we have the hemagglutinin esterase dimer, which is used for research purpose. So whenever the coronavirus, SARS-CoV-2, as we call it, enters our body, there is a basic response even for the previously unimmunized person. So the virus comes in, it attaches to the surface with the help of the ACE receptors, which apparently in the children is a bit less as compared to the adults, and probably would be one of the key factors which helps in reducing the pediatric load of COVID. Once it has entered the cell, what the cell does is, our body cell does is try to get the antigen to the surface so that our immune system can start kicking in. And there are the CD4 plus helper cells, which can respond in two ways. So one of them is an antibody mediated immunity, so that the IgG, specifically IgM, specifically goes and tries to neutralize the virus, so kills the virus in the body. This will be outside the cell, not within the cell. However, there is another cell-mediated immunity, which then tries to tackle the virus which has already entered our cell. Unfortunately, here, it cannot kill the virus within, so it takes the next best step, it kills the cell without. So it will kill the body cells, and that response is what you see as the COVID response in adults and children. So it is basically the body fighting the COVID indirectly by inducing a response against its own cells is what leads to the so-called inflammatory response. And that is how things move. So this is how the whole virus works. This is how the body tries to attack it directly via antibodies and indirectly via cell-mediated immunity, whereby there is sufficient harm done in specific people and it can create a lot of issues. We also talk about variants. So there is a good amount, whenever a new virus, history has told us that whenever there is a new virus which attacks the humans, there is a constant mutation till there is a balance formed between the host, which is us, and the vector, which is the virus itself. So there has to be a balance between the two so that both may survive. For a virus to have the host killed does not benefit the virus. So the idea, contrary to popular belief, is that COVID does not kill us. It is the inflammatory response against COVID which creates harm. And the virus actually would love to reside within the human body and stay on so that there is coexistence with the host and the vector itself. So we do look at variants, and we have variants of interest, which just is scientific, that minor things, nothing much. And then there is the more important variant of concern. So variant of concern is when we have an increase in the transmissibility. So the current Omicron apparently is hypertransmissible. That's why it becomes a variant of concern. So it changes the infectivity, the transmissibility of the virus, or there's an increase in the virulence. So the initial alpha strain and the beta strains actually created a lot of havoc. The delta took it further. So now it's only logical that the virus, without understanding, tries to understand that going overboard does not help. So let's have a milder form which we can coexist in. So thereby, they try to move from concern to just simple interest. So hopefully the Omicron, only time would tell us, becomes just a variant finally of interest rather than a variant of concern. So that is why we need to also understand why certain strains are labeled as VOC and why some of them are labeled as VOI. So these are the different types of viruses depending on what do we make a vaccine against consist of. So you can have the whole virus. you can either attenuate it, make it mild, and create a vaccine whereby when introduced into the body, will induce a good immune response so that if there is a natural infection, it will immediately get subdued because of the hyperimmune response. Or you can kill the same virus. So instead of having a live, as Dr. Pankaj Parikh was talking about, live attenuated influenza vaccine has benefit because it gently proliferates a bit. So the response is much better and it's intact. Or you could have a killed vaccine. So when you have a killed vaccine, you denature the virus, but you keep it intact so that hopefully an antibody response would be maintained by the body against the killed virus, maybe milder, so that when there is a genuine infection, you'll get a very good response and it protects us. So the MMR vaccine was a classical example of live attenuated. And for a whole killed vaccine for us in COVID times itself, Bharat Biotech makes Covaxin, which is a whole virus vaccine. So that is that. Then you can try to use viral vector. So you take another virus, code it with the original COVID virus, part of it, and that virus then enters the non-harming virus, or the attenuated virus enters the body, replicates, and induces a response, so that when you do, or if you do get a natural infection, it would help. So Ebola is that type, and that is why we've used a lot of this, and we are aware of how these vaccines work. Then, of course, we have protein subunit. The classical example now we have is Novavax. In India, it would come as Covavax. So you have a small set of the protein, which is then attached and then introduced into the body. So you have definitive immune response against that. Then you have the DNA virus. So the DNA virus, the classical example is from Zydus. So that is specifically now supposed to be used in the pediatric population. So there is no parallel response so far, no parallel vaccine available, but the DNA can be used because when the virus is an RNA, to replicate it needs to become a DNA. So the other half is taken from the host, makes a DNA, starts replicating copies. So here the idea is to actually block this passage. So that is why we have a DNA vaccine. And of course, the last one, which was the first set of vaccines available, the mRNA vaccine. So this is against the RNA unit itself, the classical being Pfizer, Moderna. These were the two vaccines which came in very strong. They have been used the most. I think we have the maximum data on that at present, and probably under the current circumstances is the most effective vaccine. So this is how different vaccines were available against COVID. At present in India, what we have very commonly is the Covaxin, right, which is a whole killed vaccine from Bharat Biotech, and Covishield, which is an adenovector ChAdOx1 vaccine. So the viral pro unit is attached to an attenuated virus itself, and then it is replicated in the human body. Of course, we will have other vaccines coming in too. Moderna is trying to do some trials, and also we will have protein-based vaccine, which I mentioned earlier. So these are the 4 types of vaccines, which some are available, some are in the trial base, and some effectively would be used in children whenever they are licensed. So these are the companies now available in India who are making the vaccines. So we have Serum Institute, Bharat Biotech, Biological E. Gamaleya is also coming up with a lighter version of its main virus. Novavax, which will be manufactured as Covax from Serum Institute, Genova, and Zydus, which specifically started off only for children. So these are the vaccines available for currently under trial purpose, but hopefully will get maximally. I wonder, how do I get rid of this? Because I suspect that is hide floating controls. Hopefully that I should have done that before. My apologies. So currently looking at research, the only research concretely available for COVID vaccination in children is from the US. And they've used the Pfizer BioNTech vaccine, which is an mRNA vaccine. The difference here is that instead of the 30 microgram dose, which is available for adults, They've cut it down into 10 micrograms and 20 micrograms. And they're still trying to figure out 10 micrograms also works very effectively. So the idea is to give 2 doses of the vaccines anywhere between 3 weeks to 6 weeks apart and hope for a response. The dosage for 5 to less than 12 years is 20 microgram, and 12 and above adults is 30 microgram. So the same thing, and they found that it is almost 91 to 100% effective. Now this is before the Omicron access. So whatever data I've got is till Delta. After that, Omicron has surprised us, but they do hope that there will be a continuity of immune response against the Omicron also. So that is the study which is established. So in the US and certain European countries, the Pfizer BioNTech is available for vaccination in children 5 years onwards. We do not have the same luxury yet, no doubt about that. We really don't have the luxury, and part of it is because we are still in the process. So every country has its own FDA, has its own DCGI regulatory bodies, which are there to ensure that first we do no harm, then we show some benefit, and that we anticipate whatever side effects there are. So we've been a bit late because we've been focusing on adult COVID, but now I think slowly, since Jan 2021, there have been numerous studies which are in process. A couple of them have finished, but the results still need to be made public. They have been made accessible to the government regulatory bodies who agree that these vaccines may be used in children, but there are still some changes they have requested for before this can be released into the public. So these are the companies who currently are in the limelight in India for vaccine production. So the Zycovid is for children. Covaxin in its current form will be available for children. So Covaxin, the advantage, I always speak a bit biased with Covaxin, is because this is an old world vaccine. You know, we've used vaccines similar to this technology since the last 25 years. And we are very much confident as to what can happen. It may not be as beneficial, but at least it's very safe. So that is the advantage of using old world technology. The new world technology like mRNA, protein subunit, these are new. We do not have equivalents. So we need to be very, very careful, because for us, the first dictum is first do no harm. Then if we can benefit, I think we should go ahead. So that becomes very important. Serum Institute is coming up with its local production of Novavax, which it will call Covavax over here. Biological E has got an RBD vaccine. Johnson & Johnson is also coming up with a vaccine. I'm not sure if it's going to be a nasal spray. I do hope so. But we still need to get details onto what exactly. But there are trials going on. As a matter of fact, there are almost 14. I'll see if I can put up that slide. In general, the side effects noted across the world where these vaccines have been used, whether under trial or under routine community service, you have local effects like pain. You may have headache, chills, muscle pain, fever, joint pain, but this is normally seen with most of our vaccines. So it is not something new which is coming up. Something new coming up is obviously an issue, and we always like to make a big thing about it because it's new, previously undefined, and that is the association of these vaccines with the heart. So apparently there is a specific set of population which does seem to be affected by the Pfizer vaccine also in children, and that is with myocarditis and pancarditis. But I sat down to read that paper, and the incidence of such a side effect, when I calculated 54 cases per million, did not make me understand much. But when I did the percentage is 0.0054. Now that is a very, very low percentage. We need to be aware. There is no vaccine on earth which is completely safe. There is always going to be some side effect or the other, usually measured in millions. So you may have 1 per million, 2 per million. I forget about the flu virus. You mentioned some figures, sir. Yeah. So they're very, very low. And I think that should not prevent us from at least vaccinating the general population, taking care that being a new vaccine, we need to observe and see how this cohort goes over 1 month, 6 months, 1 year, and 5 years. Once we clear 5 years, usually we will find that the effect of the vaccination should not be correlating with any illness. So that becomes very important to understand that yes, there are side effects. The serious side effects are extremely rare, and that should not prevent us whenever it begins from vaccinating my children. That is very important. So these are the vaccine trials which were registered as early as October 2020 and are still being registered. So various companies, as I said, Novavax, Serum Institute, some from US, Zydus, Russia, Oxford, which is your Covishield people, all of them are trying various vaccines for children. But obviously, if they are for children, they're also for adults. So I think there's a dual trial going on. First, they usually, as the dictum goes, first they test it on adults, and then they take it further and do it on children. So these are at least 14 trials that I'm aware of going on. One of them is complete. Sorry, 2 of them are complete, but I have not been able to get the scientific papers because I think they're still in the regulatory phase. So till that gets cleared, I do not think they'll release the data on that. We also have most of the vaccines so far that we mentioned, except for one, they are all injectables. Most of them are intramuscular injections. Children do not like injections, obviously. Adults don't like injections, so children definitely don't like injections. And for them, there are some studies going on with attempting to use intranasal spray. Now, intranasal spray has been used as a vaccine modality in the past. Flu vaccine was one. There were a couple of others, I forget now, but they've not been very successful. But here, what we know is that the virus enters through the respiratory system. So it first gets attached to the respiratory mucosa of the upper airway. So if we manage to get that being prevented itself, then I think that prevents the infection and then the after effects of the infection. So this is the intranasal SARS-CoV vaccine. This is being developed by Bharat Biotech. And we are hoping that we get some good results, hopefully by mid next year. So it takes time, but it will happen. And I think this becomes an easy thing as an office practice to just give the nasal spray without any side effects and then move on. So these are most of the vaccines that we have looked up. Some people have naughtily put up advertisements saying, register for pediatric COVID vaccination. And then second last line in fine print. We always say we never read the fine print as once the government approves of it, So I think we need to be very clear and transparent that we are still not in the process of using pediatric COVID vaccine in public. Very important to understand that. The moment the government gives us the regulations and allows for it, we will be ready for it. And obviously the initial vaccines are going to be intramuscular. They're not going to be oral or intranasal. And we still do not know how long the effect lasts. The closest sisterly vaccine would be what Sir described, the flu vaccine, where we've had to give annual shots. The basis of that is mutations. So the same thing happens with SARS-CoV-2. There is an immense amount of mutation. So we do expect that till we reach a point where the basic protein unit forms a good immune system for us, we will continue to have annual shots of the variation in the genetic structure of these viruses. So that becomes very important to understand. So yes, children are not affected. Less children die as compared to adults, but they may be good carriers. And children are the favorite of their grandparents. So we need to protect them also. So vaccinating the children will induce a good social immune system and prevent the seniors from getting the disease. We are yet to ascertain short-term and long-term effect of this vaccine in children. But once again, that is what happens. The chickenpox vaccine was introduced in Japan in 1984-85. To come to India, it took them 22 years. To be accepted took another 12 years. And it is only today that we use chickenpox vaccine as a routine. The past dictum by most of the older people, society, pediatrician was, ek time thawa do, ena pache lifelong immunity. But the benefit we found to giving active chickenpox vaccine is that herpes zoster also got suppressed. So that was a good benefit for us. And people die. As we go into more and more immune functions, we realize there's a lot of immune dysfunction in the population, which we've never been aware of before. Everything was labeled as tuberculosis. Everything was labeled as something else. Now we know there are many more things besides these common infections. So we need to protect the population from that. Internationally, children are being vaccinated, and we are just awaiting a release from the government. At present, they are busy trying to vaccinate the adults who not only have not yet got vaccinated for various reasons. The second dose, I think, is quite awaited in quite a few of them. So we hope that once that is over, then we can start the vaccination. So schooling can begin. Development of the child is maximum in the first 2 years, 3 years. If they are going to sit at home and nothing else is going to happen, the development is compromised, and we are not going to have as good a population of children which we had in the past. School gets affected, play gets affected, development gets affected. So all of this needs to be considered, and we need to make sure that we are in a position to initiate this as soon as possible. Thank you.
Only 24 by 7, you have to be get protected from the mosquito bite. So in that case, we have Dr. Bruchel Shamkova. She is going to discuss about the current management guidelines of the pediatric dengue fever. So may I have Dr.
Good afternoon, everyone. I would like to thank Mehta sir, Rahul sir, and Bombay Ward Medical Association for giving me this opportunity. Today, my topic is current management guidelines in dengue fever. So, as we know, we see dengue fever day to day in our practice. There are 300 to 400 infections per year, as described by WHO. The vector we know is in India, Aedes aegypti, in most of the urban areas. Aedes albopictus is also incriminated in many areas. There are also other species, Aedes polynesis and Aedes nevius, which are the secondary vectors in other countries. The climatic conditions, particularly temperature and rainfall, play a vital role in the life cycle, breeding and longevity of vectors and thus transmission of disease. Aedes mosquito is a daytime feeder and can fly up to a distance of 400 meters. So, in absence of any vaccine and any specific therapy, vector control is very significant in preventing the disease transmission. The life cycle, I'll tell you in short. Aedes aegypti usually becomes infected with dengue virus when it takes a blood meal from an infected person during the viremia phase of the illness. After an extrinsic incubation period of 8 to 10 days, the mosquito becomes infected and it transmits via the bite and injects when it bites a person and injects its saliva into the wound of a person, and the cycle of dengue continues. Dengue begins abruptly after an intrinsic incubation period of 4 to 7 days. It can range from 3 to around 14 days also. There is also evidence that there is a vertical transmission of the virus from infected female mosquitoes to the next generation. There are few reports of dengue transmission through blood transfusion and organ transplantation also. There are also reports of congenital dengue infections occurring in neonates born to mothers infected in the 3rd trimester of pregnancy. What is the pathogenesis of dengue? The agent is categorized under the genus Flavivirus. It is a single-stranded RNA. It is small in size, around 50 nanometer. There are 4 dengue serotypes, dengue 1, 2, 3, and 4. Although all 4 serotypes are antigenically similar, still they are different enough to elicit cross-protection only for a few months after the infection by any one of them. Infection with one serotype confers lifelong immunity to that virus serotype only. The dengue virus genome is composed of 3 structural proteins. There is a co-protein C, a membrane protein M, and an envelope protein, and several non-structural proteins, NS1, NS1, NS2A, B, NS3, NS4, B, and 5. The function of all these NS proteins are not well characterized. However, NS1 protein has been shown to interact with the host immune system and evoke T-cell response. So in dengue virus infection, patients have measurable levels of NS1 protein in the blood, which is the diagnostic marker of the infection. How does dengue fever work? What are the various mechanisms that are proposed to explain the signs and symptoms of dengue? There are 4 mechanisms and have the following central themes. That is antibody-dependent enhancement, cytokine storm, vasculopathy, and coagulopathy. So the dengue virus is taken up initially by dendritic cells, and after antigen processing is presented to the T cells. The dengue has 3 principal proteins that are targeted by the host immune response. That is E protein, precursor M protein, and NS1. E protein specific antibodies cause neutralization of the infection and block attachment to the cell receptors. NS1 is not found in the virion, and NS1 specific antibodies are therefore incapable of neutralization of the infection. Precursor M specific antibodies binds partially to matured virions only, and there is also poor neutralization of virus. But it can mediate antibody response and cytokine storm. Now, as we know, there are 2 types of antibodies, neutralizing and non-neutralizing antibodies. And after infection with the virus, after formation of virus antibody complex, viral entry is enhanced into the host cells, specifically dendritic cells and macrophages. And once inside the cell, the virus replicates and generates high virus titers in the blood. This phenomenon is called as antibody-dependent enhancement of the infection. Okay. Once dengue virus specific CD4+ and 8+ T cells lyse dengue virus infected cells and produce cytokines such as interferon gamma, TNF alpha, and lymphotoxin, all of which result in the cytokine storm. The 3rd mechanism that is proposed is vasculopathy. While most symptomatic patients, they recover after a short illness, some of them develop vasculopathy. There is capillary leakage and hemorrhagic diathesis. There is a transient disturbance in the function of endothelial glycocalyx layer during the infection, and it leads to temporary alteration in the characteristics of the fibromatics of the endothelium. Anti-NS1 antibody acts as autoantibodies that cross-react with platelets and non-infected endothelial cells and trigger intracellular signaling, leading to disturbance in the capillary permeability. So there is diffuse increase in capillary permeability, and it manifests as plasma leakage, which has signs which shows hemoconcentration, pleural and pericardial effusion, ascites, and various organ involvement. The severity of organ involvement and shock correlates with the degree of vasculopathy. This is usually seen in the critical phase, that is during the day 3rd to day 7th of the fever. The last mechanism that is proposed is coagulopathy. The causes of coagulopathy usually seen in dengue fever are multifactorial, and exact underlying mechanisms remain unclear. An increase in APTT and reduction in fibrinogen concentrations are relatively consistent findings seen in these cases. Thrombocytopenia associated with coagulopathy increases the severity of the hemorrhage. There is a release of heparin sulfate or chondroitin sulfate from glycocalyx, which is also found to be a contributing factor to the coagulopathy. So, when there is a bite with a mosquito, with Aedes aegypti mosquito, there is a dengue virus which causes infection, via direct and indirect cellular injury. There is cellular injury, there is endothelial damage, there is macrophage activation, platelet destruction, and indirectly it causes production of antibodies, cytokine storm, vasculopathy, coagulopathy, and all of these lead to severe dengue with multi-organ involvement, shock, massive bleeding, and multi-organ failure. So what is the WHO case definition of dengue fever? A case compatible with clinical description of dengue fever during the outbreak and or non-ELISA based NS1 or IgM should be positive. If a confirmed case is a case compatible with clinical description of dengue fever with at least one of the following, that is demonstration of either dengue virus antigen, that is by NS1 ELISA, demonstration of IgM antibody titer by ELISA in the single serum sample, or IgG seroconversion in the paired sera after 2 weeks with a 4-fold increase in the IgG titer, detection of viral nucleic acid by PCR, or isolation of the virus from serum, plasma, or leukocytes. Okay, the 3 phases of dengue fever, the clinical progression is seen as in the form of febrile phase, critical phase, and convalescent phase. The febrile phase is usually seen in the first 3 to 4 days of fever. The onset is sometimes biphasic, lasting with 2 to 7 days, associated with headache, flushing, retroorbital pain, myalgia, and rash, maculopapular erythematous rash, which usually appears after 3rd or 4th day of fever. And it is seen on the face, neck, and other parts of the body. The critical phase or the leaky phase, this is seen after the 3rd to 7th day of fever. During this phase, plasma leakage and hemoconcentration occurs, and the patient develops hypertension, fluid accumulation in pleural, pericardial, and other serous cavities, and it can cause severe metabolic derangements. The period usually lasts for around 36 to 48 hours. After that, on the day 7th to 10th day of fever, there is the recovery phase. During this phase, the extracellular fluid which was lost due to capillary leakage returns to the circulatory system, and the signs and symptoms of patients improve. That is, the patient passes more amount of urine. There is no there is more improvement. The only complication that can occur during this period is pulmonary edema due to fluid overload if we do not keep a check and periodically review our fluid replacement. Okay. So case classification as per the severity for dengue. The dengue infection is classified as symptomatic or asymptomatic, and the symptomatic infection is categorized into mild, moderate, and severe. The mild infection is usually fever of 2 to 7 days with presenting with nausea, vomiting, headache, retroorbital pain, myalgia, arthralgia, and leukopenia. The moderate symptomatic infection presents with either warning signs or symptoms, or with high risk comorbid conditions like infants, old age, pregnancy, patients on immunosuppressive drugs, on chronic anticoagulations, having chronic infections like TB, HIV, diabetes, hypertension, or any coagulation disorders. And dengue with warning signs and symptoms, we have to keep monitoring for recurrent vomiting, abdominal pain, tenderness, lethargy, pleural effusion, ascites, minor bleeding, rapid pulse, narrow pulse pressure, hypertension, hepatomegaly, rise in hematocrit, and rapid fall in platelet. The severe infection is any case of dengue fever with one or more of the following, that is shock, severe multi-organ involvement, and severe bleeding. So now we come to the management of dengue fever. In the management of mild dengue infection without warning signs, these patients usually have fever, body ache, rashes, and minor bleeding, and or maybe and they have to be treated symptomatically. We usually give paracetamol. It's better to avoid salicylates and NSAIDs. And patient should be encouraged to drink plenty of oral fluids, keep a watch on urine output. And all these patients need regular monitoring by primary care physician who should monitor the platelets for patients for warning signs, along with CBCs showing hematocrit and platelet count. Any patient who develops the warning signs should be admitted. So the management of patient with the warning signs is we have to start fluids. Fluid volume replacement has to be given, and here the patients are here is the algorithm for patient presenting with hemorrhagic tendencies, thrombocytopenia, or there is a rise in hematocrit by more than 20%. So what we do is we initiate IV fluid therapy at 6 ml per kg per hour. Usually crystalloid solution, NS replacement is given over 1 to 2 hours. After that, we check the hematocrit. So if there is an improvement, then we try to descalate the therapy. From 6 the 6 ml per kg per hour, we have to come down the fluid to 3 and then 3 to 1.5 ml per kg per hour and continue it for 20 to 48 hours. And then reassess the child, and if there is still the child is improved, then you discontinue the therapy after 24 to 48 hours. If the hematocrit rises even after giving 6 ml per kg per hour of crystalloid therapy, then you increase the IV fluid every 2 hourly up to 10 ml per kg per hour, right? If there is a and then again reassess the child after 2 hours, see the CBC and hematocrit. If the hematocrit rises, if the hematocrit falls, you suspect internal hemorrhage, then that is the time you give blood transfusion. You give packed cells around 5 ml per kg. And if after that, when there is improvement, you de-escalate the fluid therapy from 10 to maintenance fluid therapy and assess the child periodically. This was for the moderate dengue. Severe dengue is any patient presenting or developing any of the following complications diagnosed to have severe dengue infection, that is severe plasma leakage, there is delayed capillary refill time, there is oliguria, fluid accumulation in serosal cavities, severe bleeding or severe organ involvement in the form of hepatomegaly, liver failure, AST or ALT more than 1,000, there is impaired consciousness, or there is myocardial dysfunction. So patient will either the patient will present with shock or bleeding. So when the patient presents with compensated shock, that is the pulse pressure is more than 20 millimeter mercury, there is hypotension, and there is a high hematocrit, that is more than 20% rise from the baseline. We initiate IV fluid therapy, 10 to 20 ml per kg of crystalloid solution, and it is given for an hour. And then you check the improvement in volume status and hematocrit. So if there is an improvement in volume status and hematocrit, you start successfully titrate the fluid every 2 hourly and try to decrease it from 10 to 6 to 1.5 to 3 ml per kg per hour, and then discontinue after 24 to 48 hours if the improvement is consistent. If there is no improvement in volume status, you check hematocrit. And if the hematocrit rises more than 45%, from previously it was 20%, now it is increased to 45%, then you give IV colloid bolus or crystalloid, and you can increase the dose, that is 10 to 20 ml per kg. Here we can give albumin 20%, or we can even give dextran we can give gelfusion as a 10 ml per kg boluses. If the hematocrit falls, you suspect again internal bleeding, and you give blood transfusion. If there is refractory hypertension, even with colloid boluses and IV fluids at 10 to 20 ml per kg per hour, then you add inotropes to the child. And during all this time, you try to titrate the fluid according to the urine output. You try to check the IVC status, the hydration of the patient, and the CBC and hematocrit. So if patient comes with decompensated shock, that is the patient comes as with cold clammy extremities, the pulse pressure is narrow, and there is severe tachycardia, or as in late stages there is bradycardia. You give oxygen and immediate rapid replacement of fluid. Now it's used, and this here it's not given over 1 hour, it is given over 15 to 30 minutes, and then you check the volume status. If the volume status improves, you de-escalate the therapy and up to the maintenance fluid, and then watch the child for 24 to 48 hours and then stop the fluids. If there is no improvement in vitals, then you repeat the boluses up to 10 to 20 ml per kg boluses can be of crystallite solution can be given. We usually give not more than 3 boluses. After that, you check the hematocrit. If the hematocrit rises, you can add 1 colloid bolus. If the hematocrit falls, you suspect hemorrhage, give blood transfusion. During all these things, you check the volume status of the child, how the child is pouring urine, how is the IVC status. If you manage to get a central line, how is the MAPS, how is the CVP of the child. And you add IV and inotropes anywhere if the patient is still in shock and in spite of giving all the boluses and giving containing fluid at 10 ml per kg per hour. If the patient, this is for the shock component, and for bleeding manifestation, platelet counts are unreliable to predict bleeding. Even with 20,000 platelets, we do not give platelet transfusion, and there have been recent RCTs in adults with confirmed DNA infection and thrombocytopenia without any persistent bleeding, even if the platelet counts are less than 20,000. Prophylactic platelet transfusion was not superior to the supportive care. So, this is taken from WHO recent guidelines for treatment of dengue fever and National Vector-Borne Disease Control Program. And the key messages are there is no specific antiviral therapy, and we have to take care of basically it is a preventable disease which can be taken care if we take care of the vector transmission and take care of ourselves. Thank you.
Thank you, Dr. Shamkova. Now we are at the end of this today's fantastic pediatric meet. And friends, don't remember we are meeting on 2nd of January. Well, there we are going to discuss Omicron. Thank you very much. Thank you for the day and wish you a very good Sunday.